very much for coming to the NASH Connect this year. This is our third year. Our first year was in Arizona, for those of you who joined us in the middle of COVID. I think we were the first live meeting for hepatology in the world. That was a hybrid meeting. So this year we expect about 500 people to the main Liver Connect meeting starting tomorrow. Of course, there are parallel sessions going on today. Now, what I wanted to do is to just introduce my co-chair, Dr. Jeffrey Lazarus, who's a really internationally known researcher who's been in the field of infectious disease, HIV, viral hepatitis, and we were lucky that he's also been now engaged in the global aspect of fatty liver disease, and has been really an instrumental sort of force behind some of the things that's going on with multi-society efforts that from AASLD standpoint, Maru is leading for nomenclature change, and Jeff has been really wonderful. He is the head of the health system team in Barcelona Institute for Global Health. He has been with WHO as well as other liver societies, and was the coach or the vice chair of the EASL Foundation for many years. So he's a great friend and has been really an incredible contributor to the field as it involves some of the policy issues and also other important topics. So he will run most of this meeting with me, but this is the list of the faculty. We are lucky that this year we have also colleagues from Europe. As you know, there is actually a hybrid part of this that's getting broadcast to others who are actually joining us virtually. I don't have to introduce you the faculty. They're all listed here. They're well-known, really key opinion leaders and experts in the field of non-alcoholic steatohepatitis. This is the agenda. Purposefully, we kept the presentations short so that we have enough time for a discussion and question and answers. These are our platinum sponsors, and of course, meetings like this cannot happen without the support of our sponsors. So thank you to all the sponsors. Our gold sponsor and silver sponsor are listed here. Just to remind you that today, after this meeting at 12:30, there's going to be another independently sponsored event, which is not accredited, looking at issues related to PBC. So for those of you who want to have lunch and be a part of this, please come back to this room. And later tonight, there is an accredited symposium related to hepatorenal syndrome, and that's between 6 to 7. So again, in this room, and there is CME for those of you who would like to claim the credit. So without further ado, we can get started, but remember that questions could come from the moderator, could come from all of you, or could come virtually. We'll have people that actually will walk around with a microphone to give you an opportunity to ask your question. So with that, I'll introduce the first speaker, and then Jeff can take over. Maru Nella, who's one of these team hepatologists, now at University of Chicago. I think Maru has contributed in every aspect of non-alcoholic fatty liver disease, or fatty liver disease, as we would hopefully know it in the future, but including leading the current guideline that was just published just a couple of months ago, and also the nomenclature for NAFLD. So thanks, Maru, for coming, and please, I suppose yours.
Thank you, Zubair. Thank you, Jeff, and thanks for the invitation to give you an update on the nomenclature process. So the WHO has specific metrics for nomenclature, and that is because they recognize the importance across various stakeholders. Patients would be at the center of this, and whatever name is given to a disease needs to be understandable, and it needs to avoid stigma. It needs to be driven by medical experts and be accurate and precise. It needs to have clear defining characteristics. And from a policymaker standpoint, it needs to have, it needs to be easy to make understood the impact of the disease. The awareness across stakeholders needs to be important and achieved, and there needs to be an associated clinical care pathway. From a societal perspective, it really cannot marginalize groups or individuals. So the Delphi consensus process is one process that can be used to help clarify complex questions. It's informed by subject matter experts, and this is very important. It's conducted using very rigorous methodology, which is characterized by anonymity of voting and reporting of results and transparency of the process. Survey rounds are then combined with in-person discussion to facilitate consensus building. And as you'll see, many of these issues are not straightforward and really needed a combination of voting and in-person discussion. This acknowledges the value of diverse opinions and assures that viewpoints are considered and discussed even if they don't reach a consensus threshold. So NAFLD has been the nomenclature of NAFLD has been sort of considered and under discussion for many, many years. This is not new. Since it was coined in 1980 and 2002 at the Single Topic Conference at ASLD put together, there were multiple alternatives that were discussed, but finally none was chosen other than NAFLD. And we sort of were there for a very long time. In 2020, in a special issue of Gastro, the name metabolic dysfunction associated fatty liver disease was proposed. And they brought up some very valid points, calling it what it is versus what it's not, noting that there's potentially a stigma associated with alcohol in the name. It provided a positive diagnosis as opposed to an exclusionary diagnosis, and it recognized the close relationships that it has with metabolic disorders. They had an international group of experts, which you can see here. I think many of us are on this. We actually ended up, I looked back, most of our panel that I'll talk to you about in a minute was actually on this, in this group. So the other thing that came with this diagnosis and this name that many of us took exception to was that the steatohepatitis was sort of eliminated as an important role and driver of disease. And there was a fairly liberal allowance of alcohol, which in many of our opinions really altered many things. And this, additionally, there was significant concern raised over the validity of the process and the impact of this change and definition change. So 2 editorials were put forward noting these concerns, and we move forward with a full Delphi process to try to address these concerns and reach consensus. So Phil Newsom and I initially engaged numerous societies who then put forward representatives. These form part of our steering committee and then engaged patient advocacy organizations as well as methodology consensus development experts such as Jeff Lazarus and Diana Romero. So we sought to address several key questions. First of all, what is the issue with the current nomenclature? What's the importance of steatohepatitis with respect to disease definition and endpoints? And how should alcohol be accounted for or not in this disease? And then importantly, how might this change disease awareness, clinical trial, regulatory approval pathways, et cetera? And can an alternate name reduce heterogeneity and allow for future advances or encompass the possibility of future advances? So this process was truly a global process. We had 264 nominees from the societies noted there formally. These were proportionate to association member size, and there were 56 countries represented in total in our group. The steering committee was truly a group of experts in this disease, even accounting for patient representatives who are very important from a disease and an awareness perspective and maybe haven't published as much of the disease. Even then, you can see a very high level of content expertise from a publication perspective as well. So the way we defined consensus, it was done a priori as a consensus threshold of greater than 67% was considered consensus. There were 4 rounds that were undertaken. You can see the rounds as they evolved and the comments that we addressed in response to the questions. Every question was allowed to have a response or a comment attached, and we did review all of these comments. So Importantly, you can't set a consensus threshold on stigma, of course, because really if anybody or any significant, even a small proportion of patients are stigmatized, that's not okay and it should be avoided. So this is it from our data sample, 61% felt non-alcoholic and the name was stigmatizing and 66% thought fatty was stigmatizing. So the areas of strong consensus are summarized here. The role of alcohol, it was quite clear that alcohol impacts the natural history of the disease and should not be allowed within the context of that definition, and that there is a very valid category that would be people who drink moderate amount of alcohol, but also have metabolic risk factors, and those should be independently studied, looked at, and have their own sort of disease name. Steatohepatitis very clearly was felt to have prognostic implications and was important to remain as a disease classifier. And then with respect to disease classification, those with steatosis that don't have metabolic risk factors should perhaps be characterized separately. The term metabolic dysfunction highlights an important aspect of disease pathophysiology. In the pediatric realm, there was really very strong consensus, specifically around the definition being less useful in histologic diagnosis in children due to aspects that are noted here, and that the term metabolic could be confusing, particularly if it's used on its own because of the other errors of metabolism noted in pediatrics. So areas of moderate consensus, so still exceeding the threshold of consensus, were that the names NAFLD and NASH are sufficiently flawed to warrant consideration of a name change, 74%. The preference of an overarching umbrella term, which was preferred in 78%, so just shy of a strong consensus threshold, so that primarily other disease types as we move forward into the future could be encompassed within it. And then with respect to the impact on clinical trials, it was felt that a change in the name only would not have a significant impact that would be more meaningful in the context of a definition change that appreciably changed the nature of the people that have been studied thus far or that are being evaluated with respect to biomarker development. And that's most notably impacted by alcohol being allowed within the name to a fairly significant degree. With respect to disease classifications, those, again, with steatohepatitis or steatosis, I mentioned already. And so we come to the overarching term. So 78% felt that there should be an overarching term. And the top three choices that we had were fatty liver disease, steatotic liver disease, and lipogenic liver disease. Fatty liver disease and steatotic liver disease were quite close, as you can see, in the percentage of first choices. When first and second choices were joined, there was a clear advantage to or numerical increase in those that wanted steatotic liver disease. But importantly, secondary to the fact that both first and second together were the highest, but also the most important deciding factor for that was that if stigma can be avoided, it should. And that landed us at SLD, which was agreed upon by the steering committee. So with respect to summarizing the next steps, I think that we do have clear consensus that the name is going to change. I'm sorry, Zobair. But that we're going to recommend that it be changed, that there is stigma associated with both non-alcoholic and fatty, and so said name will not include those terms. The overarching term that's been chosen is steatotic liver disease, and the definition will not include more liberal alcohol intake and will have a metabolic qualifier. That was also a majority opinion as well. What we're waiting on finalization is the replacement term, an acronym for NAFLD, and the specifics of the revised definition. So there is a committee that has been comprised of two members of the steering committee, and then the rest of the panel is completely external to the process, representing all continents with permanent inhabitants. And they have come up with a recommendation for a new acronym and the sub-acronyms, as well as the definition, which is still not completely revised. Pediatricians as well have their own, will have their own specific subtypes as well. And I think with that, I will close. And thank you for your attention.
Thanks, Maru. I think that'd be an incredible accomplishment if we can get through just the argument across the pond about what this disease is really for hepatologists. So I think that'd be great. So the next speaker is Jeff Lazaris, who's that I've already introduced to you. And he's going to really talk about the burden of disease, and especially how do we actually make a pitch to international organization like WHO to consider non-alcoholic fatty liver disease, at least for now, as one of the important NCDs. So Jeff, please.
Thank you very much for the introduction, Zubair, and thank you to the Foundation for the opportunity to talk about expanding the fatty liver disease community of practice, moving from the clinical to public health and policy aspects of this condition, which we know has very little public awareness and often very little attention in our healthcare systems. So I'll be talking specifically about evolving NAFLD models of care, the current burden, and future perspectives. So we know that the NAFLD prevalence is increasing. So from the last meta-analyses that you published, we now estimate more than 1 in 3 adults living with fatty liver disease. We know that data at the national level is not always complete, but this shows how ubiquitous, how highly prevalent fatty liver disease is. Tomorrow, I'll be speaking about disparities and health inequities, and I'll be looking at specific populations, but I just wanted to mention the importance, and this is also a segue into the next talk, of looking at what the fatty liver disease burden is in particular populations in this study that just came out that found also about a 38% with a very high confidence interval in fatty liver disease among people living with HIV. So we need to grow our global prevalence knowledge and look at specific populations that also have a very high prevalence. We know that obesity and metabolic syndrome are major drivers of the increase in NAFLD. Here you can see the obesity prevalence map. It ranges, I would say, from very high to extremely high in almost every country in the world from which we have data. And global NAFLD and NASH prevalence in patients with type 2 diabetes is also very high, with estimates of more than 1/2 of people with type 2 diabetes also having NAFLD, more than 1/3 with NASH, and 17% with advanced fibrosis. It was mentioned in the introduction that I worked for the World Health Organization earlier. I was there for 11 years, and I remember when we were told that people with tuberculosis should be tested for HIV. It seemed very obvious, but there was no recommendation. It wasn't being carried out routinely, and it really helped to have a multilateral organization like WHO pass that kind of global guidance. We need the same thing, I think, for diabetes. Everyone needs to be tested for fatty liver disease. That's not the case, but that's also getting ahead of myself and will be discussed later in this NASH Connect session. So, looking at the prevalence of NAFLD, advanced fibrosis, cirrhosis, HCC in people living with type 2 diabetes, a US study found that 1 in 70 diabetics have advanced liver fibrosis if they're obese, 1 in 5. And with these numbers, screening was recommended. When was this screening recommended? Already back in 2012. So when I saw this study preparing for the talk, I thought, well, this must be recent since it's not happening. So the question for the panel will also be, why is this still not the case when it was recommended already over a decade ago? Current ADA guidelines on NAFLD raising this issue and saying that patients with type 2 diabetes or prediabetes and elevated liver enzymes or fatty liver disease on ultrasound should be evaluated for the presence of NASH and liver fibrosis. We know that NAFLD is a cardiovascular risk factor. So this is growing in attention, growing in debate, more and more studies raising this issue. Yet I think if we were at a meeting on cardiovascular disease, we wouldn't hear fatty liver disease or probably the liver mentioned very much at all. So as we expand the model of care, we need to be looking to our clinical colleagues in other fields, not just endocrinology, but also cardiology, to understand what it will take to get this on the agenda there. And the implications for management and care pathways, I won't go into detail, and we have a treatment session coming up following this one, but we know that we need a minimal metabolic assessment for everyone with NAFLD, looking at dyslipidemia, hypertension, obesity, and further workup for cardiovascular disease and other conditions as appropriate. For people with obesity and or diabetes, we need that workup for NAFLD and liver fibrosis. I would probably delete as appropriate and just say for everyone. And if cirrhosis, will also benefit from screening for liver cancer. So treatments that benefit both NAFLD, and there are many treatment experts in the room. So I'll just remind us that lifestyle interventions, along with metabolic drugs, when necessary, bariatric surgery. But we need to be thinking broadly about what to do with NASH drugs, NASH specific drugs in the pipeline. We need that focus on lifestyle interventions as well. And we'll hear more about that from Shiraz Elbersagi in the next session. The economic impact of NAFLD and NASH, this is incredibly important when we start to advocate to payers, to health systems administrators, to policymakers. I won't go through all the numbers in this study that Jörn Schattenberg here in the audience led, along with many colleagues, but when talking about billions of dollars in economic burden, both in estimated indirect costs, but also in direct costs to the health system. It's helpful to break this down by country, to break it down by states or regions, depending where you live, because this is an important advocacy tool. If they're not going to pay attention to the high prevalence and the health burden and all of the comorbidities along with NAFLD, that NAFLD is a risk factor for, we can also argue with the numbers. That's why when I was at the EASL International Liver Foundation, we, at least in the absence of WHO doing so, called this a public health emergency, pointing out that this was a global issue affecting more than a third of the adult population. It has significant impact and serious health, economic, and social implications, but it's also a complex challenge, requires us to work across disciplines and sectors to find solutions. And it's a silent condition. It's received very little attention from policymakers and very little attention from the public health community and no attention from the World Health Organization. While at the foundation a few years ago, we led a global review of NAFLD and NASH related policies. We reached out to experts in 102 countries to look at the policies that should be in place to be well prepared to address fatty liver disease. Close to a third of the countries received an overall score of 0. All of the countries would have failed had this been an exam, but again, a third at 0, telling numbers for how well the world is prepared to address this. We hope the results can assist countries in identifying priority actions. For some of those countries, it's going to be a lot of priority actions, but we had various domains, and this can be used to help track progress over time and improve national, regional, and global responses to this. Within that study, we asked questions like, do you have a written NAFLD or NASH strategy or action plan? And while it may not have been so surprising to find that at that time, no country did, now India and the US are along the way, we then asked, well, if you have an obesity action plan or a CVD action plan or a diabetes or a healthy habits and nutrition action plan, is fatty liver disease mentioned at all in that plan? It wasn't mentioned in most plans, even in passing. When you did a simple word search for the word liver, you often found the word liver as a part of the word deliver, to deliver on healthy habits, to deliver on diabetes, but not to deliver on the liver. The fatty, excuse me. So the EASL International Liver Foundation, thanks. So the EASL International Liver Foundation decided we really need to do something about this urgently, as already mentioned. So we engaged the Wilton Park think tank in the United Kingdom, a think tank that convenes experts on particular subject matter from around the world behind closed doors to discuss issues with facilitated moderation. We weren't able to hold our meeting like you were outside, so we held virtual meetings the first 2 years with 50, 60 experts from around the world discussing a range of fatty liver disease issues, but very much focused on public health health systems and policy issues. It was the first time we took a really broad look at NAFLD and NASH. We published a report calling for this to be put onto the WHO agenda and to be addressed around the world from this perspective as well. We also engaged the economists, their intelligence unit, and thought, we'll go to the top, we'll work with the economists because this is also an economics issue, not that they're solely focused on that. And we engaged experts in Asia, in Latin America, and the Middle East. We held 14 workshops over a period of 12 months. There's a report you can see available where we outlined calls to actions at the regional level and the importance of expanding models of care to integrate NAFLD into other non-communicable disease activities. And now experts from those regions are taking that forward. So that's how we started to get fatty liver disease into and embedded into the global health and regional policy issue agendas. We also looked at or ran a systematic review of all of the published models of care that answered specifically the what, where, who, and how of fatty liver disease models of care. What would we recommend for an ideal model of care? You can see on the upper left that one of the highlights was improved screening, improved diagnostics and through using non-invasive tests, but also the importance of establishing coordinated and integrated care systems or care across the entire healthcare system. We talked about the importance of multidisciplinary team approaches and how we can integrate services, whether it was through a one-stop shop on a certain day for your NASH or NAFLD NASH clinic, or whether it was through improved referral systems that were more person-centric, easier to follow, easier to adhere to for the patient when they were assigned to that pathway. We know the multidisciplinary approach for the management of NAFLD is getting increased attention, and here we have this call to action in gastro. And as we've looked, as I mentioned, on the importance of NITs to assess fibrosis levels, we thought, well, if we're really going to get NITs to start to replace the liver biopsy to be more widespread, we need to make sure that NITs are being used uniformly, following the guidelines around the world. So in this small sample of 35 clinicians, we found that 14 different NITs were used, of which FIB4 and TE were the most common. But the cutoffs used for the same NITs for NAFLD risk stratification varied between clinicians. So we discussed this already at AASLD last November. Why are clinicians not following the guidelines when they're implementing screening using the same NITs? Now, to have this kind of global response, we really need to get ourselves all onto the same page. So while we have the nomenclature consensus process to agree on the name and the definition, earlier we had a consensus process to get agreement on addressing fatty liver disease as a public health threat, as this session is called, as a public health challenge, using language from WHO that they use for other conditions, including liver conditions like viral hepatitis, where in 2016, they called for the elimination of viral hepatitis as a public health threat. Again, in the absence of WHO doing this, we did it, a group of more than 200 collaborators from almost 100 countries working for over a year to get a public health consensus on NAFLD. We came up with a series of recommendations. I won't go through them all, but we highlighted the importance of leadership for the NAFLD public health agenda, which is sorely lacking. Further understanding the human and economic burden, raising awareness, addressing treatment and care, looking at the policy strategies and a whole of society approach to fatty liver disease. We will not be able to get ourselves out of this challenge, out of this threat by addressing it in a silo focused just on liver health care. And we addressed patient and community perspectives and further addressed defining and implementing models of care. The EASL Lancet Commission took this one step further, did a deep dive into fatty liver disease, looking at both the prevalence and set out a series of concrete recommendations, including recognizing the impact of marketing alcohol, but also ultra processed and high sugar foods and drinks to children, advocating for improved health promotion through access to healthy diets and physical activity, and stating very clearly that, in their words, the endocrinologists should not miss NAFLD. People with type 2 diabetes have a significantly increased risk, as already mentioned, and developing multi-stakeholder education programs. We need to get education programs just out of the specific clinical area and be more multi-stakeholder, and they should also address all forms of stigma. So the Lancet Commission specifically called out stigma and said it's not just about stigma like Dr. Ranella was talking about around certain words. There's also public stigma, there's structural stigma, there's also stigma in our healthcare settings. We need to understand it, we need to identify it and understand how it impacts on self-stigma and what self-stigma causes, including care avoidance and delayed care and increases in the number of people with severe liver disease. We then finally, as I start to conclude, took this one step further and said, if we're really going to go global, we need to think about the Sustainable Development Goals, the 17 goals that all members of the United Nations agreed on in the year 2015 to be reached by the year 2030. If liver wasn't mentioned really at all, except in passing for combating viral hepatitis, we decided to rejig the image, put liver in the center, and through a Delphi process, identify which goals and which targets are specifically related to fatty liver disease and that countries are already working towards, but we could use to advocate and engage with them on why they should highlight fatty liver disease even more. I think if we're going to be successful with fatty liver disease, we need to position it well in the ongoing non-communicable disease agenda. So where should NAFLD sit in the NCD agenda? We've come up with a list of recommendations. I won't go through them all, but this is about building partnerships and collaborations beyond the liver health community and establishing a collaborative response to fatty liver disease and other NCDs. When you look now at the NCD Alliance and other large organizations with hundreds of members addressing non-communicable diseases, you really won't see any organizations addressing fatty liver disease. So that's a good place for us to start. We need to identify where we can lead efforts, but where they can lead efforts, and we can embed our efforts under their leadership. So what will it take to do this? How can we strengthen our approach? Well, we need to engage with diabetes, obesity, and heart disease communities. Easier said than done, but there's been good inroads working together with diabetes and obesity communities, at least. And we need to engage with a wide range of patient groups, not just those patient groups focusing on liver care, but also those going beyond the liver, including diabetes, obesity, and cancer. So some of those key actions include not only having an organized agenda, but having an agenda that clearly sets out what research and action is required. Many of you are in the room are involved in the more than 300 experts from over 100 countries who have gone through a Delphi process. And thank you to everyone who responded again to more surveys, setting research priorities and action priorities to help us have an agenda for the decade moving ahead to guide the field forward to address this also from a public health and policy perspective. Moving the issue outside of the liver health space, as mentioned, and establishing multi-stakeholder collaborations and engaging with WHO, the international organizations, including AASLD, ALE, Apostle, and EASL will hold an event for the first time at the World Health Assembly. This is the decision-making, the governance structure above the World Health Organization. We'll hold a side event there in May on fatty liver disease to start engaging with the World Health Organization so they start to take this condition seriously there. We're also working to establish a global coalition called Healthy Livers, Healthy Lives, again, led by the four international liver health or liver disease organizations, but with representatives from national organizations around the world so that we can have a transparent, inclusive global collaboration on the research and action priorities that we're setting and hold a series of town hall meetings and discussions around the world to help stakeholders at that level take this agenda forward. So we have a long way to go, I think, to make NAFLD a public health priority and ensure adequate responses from the local to the global level. I've chosen to be optimistic. I think we've come a long way from 1980. We also have a lot more people with lived experience. Probably the only bright light to that very high prevalence is that we have a lot of people we can engage who need to understand that they have fatty liver disease and understand the seriousness of this condition. So we have more momentum than ever, a growing coalition of experts. This is expanding slowly across disciplines, but ready to advance this agenda. So we need to take this coalition, move it forward, and ensure that public health is on the fatty liver disease agenda. So thank you to the more than 500 people who have been involved in all of these efforts around the world. And thank you again to the foundation for the opportunity to share this experience.
Thank you very much, Jeff, for this excellent presentation to sort of put everything into perspective about fatty liver disease and sort of global and policy side of things. I think one of the challenges we've had really has to do with awareness at all different sort of levels, at the patient level, at the provider level, especially at the subspecialist, at the policymaker level, that we need to address. And let's see, where's Kathleen Corey? Oh, here we are. Kathleen is sitting to my right, and Kathleen, of course, is one of our esteemed hepatologists from Mass General. She's the director of the Fatty Liver Clinic at Mass General, and has been in the field of fatty liver disease for quite a while, in publishing quite a bit in all aspects, including cardiovascular sort of association with fatty liver disease, but also very interested in the issues of awareness about fatty liver disease. So, Kathleen, you can give us an update about awareness. Thank you.
Good morning. Thanks so much. Thanks so much to the organizers for having me. It's been an exciting morning hearing about all the progress we're making, and I don't want to throw too much cold water on that, but I'll talk about just where we're lacking in awareness, which will help us identify where we can improve. So my take-home messages today, if you're needing some coffee and you just want to get the important parts of my talk, here they are. Among primary care physicians or general practitioners, NAFLD is thought to be still a low prevalence disease, that non-invasive tests or NITs are rarely used, and further referral to specialists is uncommon, although all of these things are improving. Patient awareness is low, even among those patients with NAFLD. And in some work from Dr. Younossi, nearly 96% of adults were unaware that they had NAFLD. And while national action plans for diabetes are common, as we've heard, no country in Europe has a national action plan for NAFLD, and further, no countries in the Americas do as well. So let's talk about primary care physicians. These are really the folks who are first seeing these patients and have incredibly difficult and busy jobs, but we need to have them as important partners in this recognition for NAFLD and NASH. And so I'll talk about a number of surveys that have been done to understand their awareness of NAFLD. So one that surprised me was that 34% of providers, PCPs, were not familiar with the term NAFLD, or non-alcoholic fatty liver disease. And over half were not familiar with the term NASH. The majority of providers believed that NAFLD was a low prevalence condition, so impacting less than 10% of their patients. And this ranged from a low of 51% to up to 75%. So we really need to start education first about the prevalence of this condition and then what these terms need. And nearly a quarter of those surveyed felt that screening for NAFLD could be performed with liver enzymes alone, which we know is going to miss the majority of our patients with NAFLD. What about screening our patients or staging our patients with NAFLD among primary care physicians? Well, knowledge about and the use of NITs was also quite low among PCPs. Ultrasound and liver enzymes, as you can see here, are used frequently to identify and to stage NAFLD, although that's not quite correct. And then 66% were unsure if NITs like the fibrosis 4 score or the ELF score could help to detect advanced fibrosis or cirrhosis. And when surveyed about NIT use, 73% said they never use NITs and 22% said rarely. So nearly 100% of primary care providers surveyed said they weren't using non-invasive testing. What about guidelines? Well, in a survey of 214 physicians, this study looked at PCPs, gastroenterologists, and hepatologists so that we could see the difference in uptake. And close to the majority of PCPs were not familiar with official guidelines. Nearly 20% of gastroenterologists were not, and nearly 6% of hepatologists were not familiar with how to screen or evaluate NAFLD. What about referrals to specialists? Well, this was quite low as well, and this is a study out of Australia that looked at differences in referral patterns between rural and city settings. They found that 41 to 64% of primary care providers had 0 referrals per month for their patients with NAFLD, that 54 to 32% had 1 to 2 referrals per month, and that only 4 to 6% were referring even 3 to 5 patients per month. So most patients are not moving forward with any specialist referrals. What about patient awareness? I think this is key. We want to have our patients empowered to be asking about NAFLD, especially if they have risk factors. There was a survey of 302 adults who were presenting to an endocrinology clinic for the management of either insulin resistance or obesity or both, so high-risk patients. Only 18% were aware of the term NAFLD, but 73% were interested in receiving education about NAFLD if they were told they were at risk. So patients are motivated, but they don't really understand what NAFLD is. Interestingly, a survey in Hong Kong of the general population, so not even high-risk patients, found a similar awareness of NAFLD, about 17%. But of those who had heard of NAFLD, 46% felt their knowledge was inadequate, 35% highly inadequate. So our patients really need more education, especially those high-risk patients. And then a study that we've heard about from Dr. Unosi's group was of 11,700 patients from 5 NHANES surveys from 2007 to 2016, and where NAFLD was determined by the fatty liver index for a multi-ethnic US population. They found that using the FLI, the prevalence of NAFLD was 36.6%. But those who were aware of their diagnosis was very low. In 2007 to 2008, only 4.4% of those with NAFLD by FLI were aware that they had NAFLD. And while this increased to 2015 to 2016, only up to 6.3%. So the majority of patients, as I mentioned, do not know that they have NAFLD and are at risk of progressive liver disease. And further, among those with NAFLD, the lowest awareness was among young patients and Black adults. So these are patients who really need to be helped to understand the prevalence of NAFLD and their risks. Now, you've heard about this more eloquently than I'll be able to discuss it, but I do think this was fascinating, first because of the graphical abstract. Very, very clear. Does your country have any written national NAFLD or NASH strategy or action plan? And 100% said no. So that really is the takeaway. This was, as you've heard, NAFLD experts in 29 countries completing a survey, and this was in 2018 or 2019, so quite close. And that they found that no country of these 29 in Europe had a national action plan. And when I looked for studies about diabetes mellitus action plans, back in 2014, 68% of European countries had an action plan. And even in 2013, when surveyed, 33% of resource-limited countries outside of Europe had diabetes action plans. So we're certainly far behind things like diabetes across the world with national action plans, although we know that some are in development. Only 34% had national guidelines for NAFLD, 24% had funded awareness campaigns, including liver disease, 14% had civil societies that address NAFLD, and 10% had national registries. And you've also heard about solutions, but I'll just point out that one important thing that for these solutions is really patient education, changing the stigma of the term, which we've heard a lot about, and then engaging health communication experts to help develop educational plans, both for the patients, as we see there's a need, as well as providers. So if you're still with me, here's what I talked about. Among primary care providers, NAFLD is believed to be a low prevalence disease. Less than 10% of patients they believe have NAFLD. They rarely use non-invasive tests and refer to specialists. Patient awareness is low, even among those with NAFLD or those who are high risk. And improving awareness, including the development of educational courses, engaging health communication experts, and terminology change is needed. Great, thank you.
Thank you very much, Kathleen. I'll ask Dr. Scott Isaacs to join us. Scott from the Atlanta Endocrine Associates. And a representative of the sorely needed collaboration we've all been calling for, so you're in charge. We have about 20 minutes now for questions and answers with the panel. We have a few microphones moving around the room, and I'll also ask if one can be brought to the front of the room so the panelists can respond. But I see a hand up. But we're going to need one microphone up front. But please go ahead. Well, we have people listening in from abroad.
Should I go first? Okay. Bob Fontana from Michigan. Nice presentation and also a little sobering at the same time. But I guess to Mary, you know, words make a huge difference and they got to be understandable. So I commend you for the work you're doing. But one of the things in and of itself is if you oversimplify, you lose context. So steatosis of the liver could be from a drug, it could be from alcohol. So is there thought to take it a step further if you say you have the bucket of steatosis of the liver, that there's got to be a secondary classification like clinically significant or advanced fibrosis, you know, something, because otherwise I think we're going to have a sort of a blurry generic term without much meaning to it. And I worry about that.
Is this working? All right, thank you, Bob. Yeah, so no, it is definitely not the replacement term. So the whole rationale behind having an umbrella term was so that underneath it, you would have the equivalent of NAFLD. You would have a separate category for the combination of those who drink moderately, which is a sizable amount of people, in conjunction with having criteria that would qualify you for NAFLD. It would also have a category for drug-induced steatosis, steatohepatitis, and then more specific things like heritable things like hypobeta-lipoproteinemia and things of that nature. So we hope that it'll actually make a little bit more granular and specific the different categories within that umbrella. Alcohol, we did not touch because it's not our purview. The only way in which alcohol is included within that umbrella, at least based on our work, would be in combination, where there's sort of dual contributors, important contributors to the disease, because we know that people who drink moderately have accelerated disease progression, and they really are an understudied group of people. And so we're sort of creating a specific category for them. And then within just focusing on the NAFLD replacement term, it will definitely be characterized by degree of activity and stage. And I would like to see actually a little bit of a dissociation from histology, in the sense that we are able to make more confident diagnoses with non-invasive tests within those categories. So that would be what I would like to see in the future. And we've discussed that as a group as well. So hopefully that clarifies.
Thank you for the answer. We have two questions over here.
Yeah, Brad Freilich, City. I applaud all the work, and I think this is right on target. The one thing that I did notice, and maybe I missed it, is that the biggest hole we have in direct translation of your message is getting payers to pay for this. And I think that it's really important that we really focus on insurance companies, on CMS, on national healthcare plans to support this endeavor. And I can tell you in my own experience, 90% of payers do not cover any of this. And even CMS has dismal coverage for people for weight loss. So it's really important that we take these efforts and directly translate it into that task.
I'll just respond briefly, and then if anyone else in the panel wants to add, particularly Zubair. I mean, I think if we go at this as a fatty liver disease as a standalone condition, it's going to be difficult to to engage the payers. But if we talk about the impact fatty liver disease has on diabetes, the relationship with obesity, if we start to package this, hopefully we can make some headway. But I'm not engaged with.
Yeah, I mean, specifically, they just don't cover obesity management, right? That's what we're talking about here. We're not talking about fatty liver disease. That's part of this problem. The bigger issue, as you've mentioned, is the metabolic syndrome. And there's no coverage for that. And it's something that we have patients come to us for help, and then they can't afford to get it treated. So if we really want to make a difference, we need to move our lobbying specifically in that area.
Yeah, maybe I'll just take a stab at it. I think part of the problem, of course, is that the awareness is actually impacting this, and that's actually at the policymaker standpoint. If you remember, hepatitis C and coverage for hepatitis C became, sort of an issue initially with all the new drugs. But as we have actually not only sort of talked about the disease, but also the treatment that was effective, and they really pushed on the policymakers. And if you remember, there was actually a document that was published by the Institute of Medicine, which is called the Academy of Medicine now, and that really actually forced the policymakers in the United States to force the payers to actually make the change. So this is going to be a journey where very early on, you're absolutely right. I think the payers is going to be a challenge, but as we actually sort of educate them about the consequences of this disease, then I think we can make some, and especially if you have effective drugs in addition to lifestyle intervention that's out there. Of course, there is treatment available. Then I'm hoping that we can make some changes. It's going to be a challenge, as you know, because there is competing sort of competing at least forces that would come to the payers for the same patients, whether they're cardiovascular, renal, or other associated comorbidities. So, but I think part of the education and raising awareness would include that as well.
Jörn.
I just wanted to make one more comment about the payers and the coverage, because you have a really good point. And it can be frustrating as a clinician when you have a patient that needs obesity treatment, but they don't have coverage. They have all the comorbidities, but they don't have diabetes, and so they don't qualify for a medication. And then instantly, all of a sudden, their blood sugar may be 5 points higher, and all of a sudden they have diabetes and they do qualify. And so it's almost this arbitrary line that's drawn. It's very frustrating. Medicare by law does not cover any obesity medications, and that's going to take literally an act of Congress to change.
Jörn?
Going to go first. Thank you. Very interesting and intense discussion. Thank you to the panelists. I think I'd like to perspective on the role of NITs, because we're discussing obesity, which is a vague term. I think hepatology has moved a strong piece forward in defining the liver disease based on NITs. Then the challenge for me here always is, where do we collect those NITs? And maybe Kathleen, you want to comment a little bit on that? I saw some of your slides discussing this aspect. So how can we implement this testing most likely with an NIT in clinical care, maybe outside of hepatology practices? What's the solution going to look like?
Well, yeah, I don't know the solution, but I totally hear what you're saying about the issue, and we really need to be having patients engage with NITs far before they see us in hepatology. It should be something when you're screening for blood pressure, screening for diabetes, if someone's found to have NAFLD, that they have an NIT. I mean, that's something that we've thought about is community-based screening, just like when you have blood pressure screens for hypertension. FibroScans are quite quick and can be done on a community basis, but I think it really does have to be at the primary care level.
Yeah, I think you're one of, that's the challenge, because the primary care, if they don't believe in the disease, then they probably will not believe in screening and linkage, which is going to be part of our challenge. But the hope is that societies like ACE, Scott is going to be the president of ACE, and even actually ADA, I'm on the committee of ADA, to review their algorithm, the ACE, and the other societies, the primary care societies in the United States are very tough. They require sort of grade level of evidence to actually recommend a screening. But we're going to have to do this, and we're going to have to push not just NITs, but algorithms and make it simple. It's got to be very simple to the primary care. Primary cares in the United States, they're dealing with so many patients. They have 5 minutes or 10 minutes for a patient with all comorbidities. So if you don't make it a part of your electronic health record with a flag and then a way to link it to a specialist, it won't work. But that's sort of our challenge.
I just want to make
Briefly.
one quick comment about that too. So I think that the pathway to increased awareness is going to be very much a multi-pronged approach. And I do think that we do need to do direct to consumer information because if the primary care doctor doesn't think about it, if you reach out to patients and you tell them if you have diabetes and you have hypertension or you've noted to have fat in your liver, that could be a major problem for you and you need, but you give them a sort of a link in that way to go back to their doctors. And I think that can also be very helpful.
Thank you, Michael. Oh, sorry.
The diversity of disorders now associated with fatty liver is becoming alarming. Polycystic ovary syndrome frequently is associated with insulin resistance and fatty liver, and the gynecologists have got no clue about it, so you're going to have to widen your net. Likewise, sleep apnea is frequently associated also with fatty liver. So what I'm trying to say is the education process is going to be alarmingly difficult because of the diversity of the conditions. One word of warning to my colleagues, be very careful of fibroscans in people who've got a body mass index of more than 35. You'll erroneously diagnose cirrhosis in 99% of the cases because they're fat infiltrating the liver. Thank you.
Thank you. Shira, Michael, brief.
Thank you. Back to NITs. One of the reasons it's not used is because there's no sufficient evidence for cost effectiveness or clinical effectiveness of screening in primary care. And one of the biggest claims is why to do screening if there's no treatment. There's no approved pharmacological treatment. And they completely ignore the dietary treatment. And they also then, it impacts policy of not providing free dietary treatments. So what can we do about it, in your opinion?
So maybe I can answer that, Shira. There is a paper that's been published in the United States. Mazen actually was the author about cost effectiveness of screening. There are actually 4 models ongoing. One for UK, because UK actually the nice part of the entity for recommendation of guidance suggests screening with FIB4 and ELF. So that has to be looked at in terms of cost effectiveness. That's ongoing. There's one for US, and there's going to be 2 or 3 for Europe. We have to show that, and as you know, that for cost effectiveness thresholds, willingness to pay is actually different in every country. And you have to show that screening is going to be effective. And currently, the treatment is actually lifestyle modification. And you are the world expert in that, of course, but I think we just have to also educate that there is actually effective treatment. You just have to use it and use it appropriately. It's not easy to use, but that's it. I think Jeff was telling me that this would be the last question. Did I answer your question?
Thank you.
Thanks, Shira.
Yeah, you're also the next speaker in the next section. So we have, I see more hands. We don't have time because we need a quick 10-minute break. Be back here for the next session, and then hopefully we can pick up some of those questions. I'd like to thank both the speakers. Kathleen Corey, Maria Ranella, thank you so much. Thank you, Scott Isaacs, for joining us on the panel, and thank you again, Zubair.
Thank you.
All right, so it's my distinct privilege to share this next session on treatment for non-alcoholic fatty liver disease. And thanks to CLDF for hosting this meeting, Zubair and Jeff, co-directors, co-organizers, for having me here at the meeting as well, and for organizing a terrific session on NASH. And what better way to start it off than disease awareness and all the conversations that happened in the last session. And we're going to take that straight into treatment. So there's probably no better person in the world to talk to us about lifestyle management than our next speaker. So Shira comes from Israel. She's a professor at the School of Public Health, Faculty of Social Awareness and Health Sciences at the University of Haifa in Israel. And she's a clinical dietitian, but literally kind of single-handedly has driven the field forward from a lifestyle manifestation perspective. I last heard her talk in Dublin, Ireland, where I still have thoughts of her lecture resonating in my mind, from bisphenol levels, in plastics to industry. Everything that she talks about is very, very interesting, very informative. And so without further ado, come on up and give us the update.
Thank you so much for this very kind introduction. So I use this one?
Yes.
Okay, thank you. So I will try to cover a lot of topics on lifestyle modification and NAFLD, and I will focus only on very, very recent studies. So this is really an update. So this slide summarizes everything we know so far about the factors involved in the treatment of NAFLD and NASH. So the most evidence-based treatment is actually weight reduction. And we know that there is a dose-response association between weight reduction and improvement in all features of NAFLD, steatosis, NASH, and fibrosis. So to reduce steatosis in most patients, we need at least 5% weight reduction. To reduce NASH, to get NASH resolution, we need 7 to 10% weight reduction. It doesn't mean that with lower weight reduction, we won't get improvement, but if we want to be sure, we need to reach at least 7% weight reduction. If we want to improve fibrosis by at least one stage, we should try to get to 10% weight reduction. But it's not all about weight reduction. And we know also that the dietary composition is important. Especially we have evidence regarding Mediterranean diet, which is important by itself to get some improvement, and physical activity, which I will discuss in the last part of my talk. And all this lifestyle modification treatment should be supported by a multidisciplinary team, ideally coordinated by primary care physician, increasing awareness among patients and referring them to lifestyle modification treatment. So this is a meta-analysis showing the effects of Mediterranean diet on patients with NAFLD. This is a meta-analysis of randomized clinical trials showing improvement in markers of fatty liver index and also in insulin resistance. The studies are usually short duration, 6 weeks to 6 months, and usually Mediterranean diet is compared to other types of diets like low-fat diet. And this is another more recent meta-analysis showing that Mediterranean diet and any caloric restriction actually reduces liver stiffness. These are randomized clinical trials and controlled clinical trials. But as said, these meta-analyses summarize usually short-term studies. So we have 2 examples of long-term studies with Mediterranean diet. These are 2 studies, randomized clinical trials conducted by the same group actually, 18 months interventions. Each study included about 300 patients. The first one on the top, we included 4 treatment arms. Mediterranean diet, which was also a low-carb diet. It was a combined diet, low-fat diet, with and without physical activity. All 4 arms reached similar weight reduction. However, liver fat reduction was most significant in the arm that combined low-carb Mediterranean diet and physical activity. There was some kind of an interaction between the physical activity and Mediterranean diet, leading to 80% liver fat reduction. The study on the bottom is again randomized clinical trial. This time they did 2 types of Mediterranean diet. They compared 2 types of Mediterranean diet. One was a regular, and the other one was called the green Mediterranean diet. It was enriched with polyphenols, mankai plant, which is rich in polyphenols, walnuts, and green tea. And also they had a reduced amount of red and processed meat consumption in this type of diet. And amazingly, although weight reduction was similar, the green Mediterranean diet led to 2-fold reduction in liver fat. So that means it's not only about weight reduction, it's also about the dietary composition, with polyphenols having beneficial effect. This is also supported by a study by my group, cross-sectional study looking at about 800 people, and we were looking at phenolic acid intake. This is subgroup of polyphenols, and we noticed that higher intake of phenolic acids was related with lower chances of having NAFLD, significant fibrosis according to fibrosis markers, and insulin resistance. Now we know that weight reduction is effective. One of the hottest topic right now is intermittent fasting or time-restricted eating. So I want to show you some very recent studies on this topic. So this is the first one. This is a randomized clinical trial, 12-week study, comparing usual care to lower carb, high fat diet to intermittent fasting. There are many types of intermittent fasting. This one is called the 5-2 diet. That means that 2 days you kind of fast, you eat very low amount of calories, and the other 5 days of the week you eat your regular diet. So both diets led to similar weight reduction of about 7.5 kilograms. And both diets, the low carb and the 5-2 diets, led to similar reduction in the amount of liver fat. So what really matters is the amount of weight reduction, actually. But that means that the patient can choose whatever diet he wants to. Both diets are effective. In a later publication of this group, they showed that the reduction in lean muscle mass was similar between the two diet arms. And this is important to show that in the 5-2 diet, although there are 2 days of fasting, it doesn't lead to a greater loss of muscle mass. Another type of this diet is alternate day fasting. And this is a new study from Cell Metabolism. Here they provided patients with either only exercise or control, combination of alternate day fasting or just alternate day fasting. The meaning of this diet is that on a fasting day, you eat like 600 calories, healthy calories, and on the feast day, you eat ad libitum, healthy but ad libitum. And what they showed that there was a similar weight reduction in these two diets. But the combination diet, the one combining exercise and alternate day fasting, led to somewhat greater reduction in liver fat content, but it wasn't statistically significantly different than the arm just giving the alternate day fasting. And they both were better than just the exercise arm. So the alternate day fasting is effective, and if you combine it with physical activity, it's even better. Now there's a study of caloric unrestricted diets on patients with both type 2 diabetes and NAFLD. This is a 6-month randomized clinical trial. And what they did, they gave a diet which is low carb, high fat, or high carb, low fat diet with different macronutrient distribution without calorie restriction. But in practice, they did reduce the caloric intake, which is a good lesson. People do that although you don't restrict them. And they had some weight reduction. The weight reduction seemed to be greater in the low carb, high fat diet than the high carb diet. And also the glycemic control seemed to be better in the low carb, high fat diet. As for liver histology, the NAFLD activity score improved in both types of diets. There was no significant difference between the two arms, looking at 2 points improvement. But when you look at 1 point improvement, there seemed to be more beneficial effect to the low carb, high fat diet. So low carb, high fat diet may be a good option for patients with NAFLD and type 2 diabetes. What about web-based intervention? So web-based intervention can be also effective. This is a study conducted in 2018 showing that if you provide people in non-randomized manner group-based intervention or web-based intervention, they reach similar weight reduction and they have similar improvement in liver disease markers as FIB4 and fatty liver index. Now they did a follow-up on these patients. All those patients without type 2 diabetes in the beginning were followed for 60 months, and they looked at type 2 diabetes incidence. So first of all, you can see on the figure on the up that weight reduction was similar in the web-based and the group-based intervention in the long-term follow-up. And then below you can see that actually the incidence of type 2 diabetes was similar in both treatment arms. And what was really actually important, whether a patient develops or does not develop type 2 diabetes, was the issue of weight reduction. If they kept a weight reduction of 5%, they were less likely to develop type 2 diabetes. And it didn't matter which kind of treatment they got, web-based or group-based. Let's move to talk about some certain foods and food groups. These are observational studies, a meta-analysis of cross-sectional and case control studies, showing us that red meat increases the risk of NAFLD, soft drinks, sugared soft drinks increase the risk of NAFLD, whereas nuts, which are very common in the Mediterranean diet, reduce the risk of NAFLD. And all the foods that you see in the gray part of the circle are actually neutral foods. That means that patients can actually eat these foods without causing any harm, no beneficial effect to the liver. So they do have what to eat. A little bit about saturated fat. This study summarizes many studies conducted on actually short-term feeding studies comparing the effect of feeding with similar amount of either saturated fat or unsaturated fat. And you can see that constantly when you overfeed people with saturated fat, you get increase in liver fat, whereas if you overfeed people with unsaturated fat, you don't see such an effect. So saturated fat is definitely bad. And this also corresponds well with the Mediterranean diet, which is high in unsaturated fat and low in saturated fat. So we have the dream of Mediterranean diet and we have the reality of Western ultra processed food diet, right? And this is a publication just came out from Harvard Public Health stating that I can't put it better, that processed foods are making us sick. It's time for the FDA and the USDA to step in. So it's definitely true, and you can see an example of ultra processed foods. What is the characteristics of this food? They undergo very sophisticated industrial processing. They are highly profitable and they are hyper palatable. They are designed to induce overeating and obesity. Of course, they have low nutritional values. They contain many ingredients and preservatives, things that you don't use in your own kitchen. And this is actually how we classify ultra-processed food. It's called the NOVA classification. The green are unprocessed or minimally processed foods. Yellow are just things that you add to your food, like salt and butter and oil. There is the group of processed food, which combines the green and the yellow foods together. It's not so bad. It's not perfect as unprocessed food, but we all eat it and it's fine. And what we are talking in our studies about is only the group of ultra-processed foods, which are really, really heavily processed and unhealthy. So we've demonstrated in one of our studies, in a cross-sectional study of about 800 people in Israel, that if you look at people who have NAFLD on ultrasound, those who eat a high amount of ultra-processed food in their diet are more likely to have metabolic syndrome. Another prospective cohort study has demonstrated a very nice dose-response association between consumption of ultra-processed foods and the risk of NAFLD. Of course, this is always adjusted for body mass index, so this is beyond obesity. This is another very nice study. Enhanced national study in the United States, and they showed an association between ultra-processed food consumption and NAFLD. But what is really interesting is that they did a lot of adjustments to other lifestyle or nutritional factors. They wanted to see if the association between ultra-processed food and NAFLD is explained by just having unhealthy diet. So they adjusted to the healthy eating index and the association persisted. They adjusted to added sugar, saturated fat, refined grains, and the association persisted. That means that not all the association between ultra-processed food and NAFLD is explained just by the fact that this is an unhealthy diet. And moving to the packing of the ultra-processed food. Ultra-processed food usually comes in cans and plastics, and this is also important because the plastics and the cans contain something called bisphenol A, BPA, which is an endocrine disrupting chemical associated with type 2 diabetes and other diseases. And it actually disrupts pancreatic beta cells function. And there is a way to reduce it in the diet. If you don't eat food that comes packed with plastics and cans, then you actually reduce the consumption. And this study looked at people with NAFLD with liver histology, and they show an association between liver inflammation and the serum levels of BPA. And they show the serum levels of people with NASH are higher than controls and people with NAFLD. And if you do 1 month low BPA diet, you do get a reduction in serum levels of BPA. So there is actually things that can be done about it. What about meat? Meat and red meat are also associated with NAFLD. In this study, we had a follow-up of 7 years on patients. We did ultrasound at baseline and in follow-up, and the outcome was new onset or persistent NAFLD. And what we show here is that if you constantly eat high amount of red and processed meat, you're more likely to have persistent or new onset NAFLD and also significant fibrosis as measured by FibroScan. So let's be all vegan or vegetarian, right? But if you want to be vegetarian, you need to do it in the right way. So this study actually looked at the quality of plant-based diets, and they looked at 2 categories of plant-based diet. It can be unhealthy, including refined grains, potatoes, sugar desserts, and sugar beverages. It is still vegetarian, right? But unhealthy, or a healthy kind of vegetarian diet with fruit and vegetables and legumes. And you see that the healthy type of diet was related with reduced risk of NAFLD, while the unhealthy type of plant-based diet was actually as bad as animal-based diet. And this study, again, in the hand showed the same. If you look at healthy plant-based diet, you get reduction in the risk, and unhealthy just increases the risk. So this umbrella review summarizes everything we know about lifestyle. It shows us, again, sugar sweetened beverages and meat. But what is interesting here is the topic of smoking. Smoking is also related with NAFLD. So maybe we need to look at lifestyle not only in terms of nutrition and physical activity and smoking separately. Maybe we need to look at all of it together. And this is the healthy lifestyle score. It combines many of these factors. In this study, the healthy lifestyle score was combined of BMI, physical activity, smoking, and sleep duration. And they categorized the population to many subgroups. And you can see that in all subgroups, a higher healthy lifestyle index was related with a lower risk of NAFLD. This is also shown in this study. This time they didn't look at NAFLD, they looked at mortality among NAFLD patients. And they show us in the green line that if you have a healthy lifestyle index, you have a lower mortality, all-cause mortality, and cardiovascular mortality. And when you look at the different components of the lifestyle score, the combination of smoking, diet, and physical activity is the most significant one to reduce cancer mortality, cardiovascular mortality, and all-cause mortality. A little bit about coffee. I love coffee, so I must talk about it. Coffee consumption, as you know, is also related with reduced risk of liver disease. And also NAFLD. It is less convincingly related with liver fat, as you can see in this study. But if you drink more than 3 cups a day, you have reduced risk of significant fibrosis or advanced fibrosis. This is also supported in this meta-analysis. Some relation with steatosis, but a stronger relation with fibrosis. And what is very important to remember that all this coffee and Mediterranean diet and avoiding sugar and red and processed meat is also good for the prevention of hepatocellular carcinoma. So just remember that we also do prevention of HCC. Physical activity reduces the amount of liver fat. This has been consistently demonstrated. But the beneficial effect of physical activity is beyond liver fat reduction. In this study, if you keep up more than 150 minutes per week of physical activity, you can prevent NAFLD, you can prevent significant fibrosis. If you do over 300 minutes per week, then the prevention is even stronger. And above 300 minutes per week, you can also prevent maybe cirrhosis. So physical activity may be beneficial beyond steatosis. This is another study showing beneficial benefits beyond steatosis. This is a study measuring physical activity objectively. And they looked in MRI at hepatic fibroinflammation. And you can see that light physical activity and more so vigorous physical activity are related with reduced hepatic fibroinflammation. Physical activity is also related with reduced risk of sarcopenia. We know the patients with NAFLD have sarcopenic obesity, right? Loss of muscle mass combined with obesity. So again, they divided the population by many subgroups, and they showed that physical activity is related with less FIB4, less significant or advanced fibrosis according to FIB4, less sarcopenia. And there was also, you can see on the left, a dose response association between the amount of physical activity and the FAST score. Okay, the fibrosis is measured by FibroScan AST score. Physical activity can also prevent mortality among patients with NAFLD. You can see on the left that those who do physical activity more than 150 minutes per week, the green and the yellow and the blue line have lower mortality. But on the right, you can see that if 50% of this physical activity is vigorous, then you get the most strong effect. This is the green line. So it also reduces mortality. This is a very nice study that I like because it looks at people who had NAFLD remission and they do a 10-year follow-up on these patients. Unfortunately, about 50% had NAFLD recurrence. What were the prediction of the factors that predicted recurrence? If they increased weight, of course, and if they stopped exercising. Okay, so this is the strongest independent predictor for recurrence of fatty liver. Starting to summarize, there are many types of diet with different macronutrient composition. The patient generally can choose with you the type of diet that he wants to do, but you need to remember that the most evidence diet is Mediterranean diet, afterwards low fat and low carb diet, and time restricted eating is gaining now some evidence. It's not better than other diets, but it is as good as, and we don't have almost any evidence on the ketogenic diet. Whatever diet they choose to do, they need to keep up the foods that you see below, the processed foods, then sugary drinks. 2 words about lean NAFLD. We know that lean patients are maybe lean, but they do have abdominal obesity greater than controls without NAFLD. A randomized clinical trial has shown that if they reduce 3 to 5% of their body weight, 50% of the patients have NAFLD remission. If you want to get remission in obese patients, in 50% of obese patients, you need to have 7 to 10% weight reduction. So lean patients can and should have some weight reduction, 3 to 5%, along with a healthier diet, low sugar, low fat diet, and of course, physical activity. This is also summarized very nicely in the recent AGA clinical practice update on the management of lean NAFLD. So some take-home messages. Diet is the cause and the treatment of NAFLD. Changes in lifestyle are hard to do, but even small ones makes a difference. Normal weight NAFLD is not an excuse to avoid diet. Dietary composition modification is also important beyond weight reduction, and physical activity may improve much more than steatosis and save lives. Thank you. Thank you.
Okay, we'll have a discussion section when we get done with the lecture. So when we get done, Shara, come back up when Scott as well. So it's my honor to introduce our next speaker and the next topic. So Christos unfortunately could not make it here today. And we're very fortunate to have Scott step in and give us a talk relative to anti-diabetic and anti-obesity drugs for managing NAFLD risk. So Scott hails from Atlanta. He is an endocrinologist there. He's in private practice, but on staff at Emory. And he also co-chaired the recent ACE guidelines and is currently the treasurer there as well. So again, great to have you here, Scott, and look forward to your presentation.
Okay, thank you, everybody. And this was kind of last minute, so my apologies in advance if there's any typos. on the slides, but we have 20 minutes to talk about anti-diabetes and anti-obesity medications for managing NAFLD risk. So I just wanted to start with a case. This is Miss Fry, named after her favorite food. And she has a medical history of metabolic syndrome, and she has obesity, prediabetes, hypertension, dyslipidemia, PCOS, and NAFLD. And she has depression, and she has a fear of injections. And you can see with her labs, she has a body mass index of 36. She has features of insulin resistance with an elevated waist circumference, acanthosis nigricans, and skin tags. And her A1C is in the pre-diabetes range, 6.4%. She has metabolic dyslipidemia, and she has elevated liver enzymes with a FIB-4 score in the low risk range. And she's currently taking metformin and sitagliptin and SGLT2 inhibitor and an ACE inhibitor. So I just wanted to bring this up for the showing the ACE NAFLD guidelines, because she would qualify for a high risk group because she has obesity and more than 2 cardiometabolic risk factors. So we have divided this into the prevention of cardiovascular disease and prevention of cirrhosis. So she's already had the fibrosis risk stratification, and she's at low risk. So really want to focus on this management of obesity and diabetes, hypertension, and atherogenic dyslipidemia. And these are all separate pages in the ACE NAFLD algorithm. So I'm just going to focus on the weight management. And of course, we just had a great talk on lifestyle. So I'm not going to talk too much about it other than to say that this is the hallmark of treatment, is always lifestyle. So we don't want to forget about that when we talk about medications. But medications are indicated as part of the management of NAFLD. And so any medication that helps with weight loss can be beneficial. And you just saw this data in the last talk, but the idea with weight loss is that more is better. And so you can start to see a little bit of improvement with 3 to 5% weight loss, but really to see that major benefit with fibrosis, you need to have at least 10% weight loss. So that's important when you think about choice of medications for the pharmacologic management of obesity. And I'm sorry, this slide is kind of hard to read. I put this together on the plane coming over here. But the point I wanted to make is that we have a number of medications that are available, and we have the first generation and the second generation. But when we're selecting medications to treat NAFLD, we really want to have those that have the greatest efficacy, the ones that you're getting at least at 10%. And so we want to think about that, especially gravitating towards these second generation medications. But the primary mechanism of action, other than orlistat, for these medications is going to be appetite suppression. So that's the thing to think about, is that they're all in one way or another acting on appetite, satiety, cravings, areas like that. So I really like this slide. This is a recent study that came out in Nature Reviews, just looking at comparing all the different anti-obesity medications. On the left is looking at long-term, and the very bottom, that's bariatric surgery. So you can see that's by far and away the most efficacious. But the point to make is that all of the medications can be effective. And so it's not like you can only use one. Any of them are going to be viable options. And the other thing on the right is just to show this comparison with human data and mouse data, just to emphasize the point that obesity is biological. This is not just a matter of willpower. And so we're seeing very similar results in humans and in mice. And you can see that the most efficacious on this one was tirzepatide, and then semaglutide, and the least efficacious was orlistat. So just showing a couple of the weight loss graphs from some of the first generation. This is naltrexone, bupropion. You can see that over a 56-week period, the average weight loss was somewhere between 6 and 8% compared to placebo, which was about 2%. And when you look at the completer data, see the majority of the patients were in that 5% category with less, and that were losing 10 to 15% of body weight. Looking at similar graph from phentermine topiramate over that 56 week period, you can see there was a little bit more efficacy. And with the lower dose, the 7.546 milligram dose, you're getting about 8 to 10% weight loss over a 12-month period. And then with the higher dose, the 1592, getting about 12% weight loss. And you can see in the weight loss categories that those that lost at least 5%, they were still in the highest, but there were more patients that also lost 10% of their weight. And so Ms. Fry was placed on phentermine topiramate, and she was titrated up to the maximum dose. And you can see her 6-month and her 12-month follow-up. She essentially lost about 10% of her weight. She did that in the first 6 months, and at 12 months, her weight was stable. So she didn't lose additional weight after 6 months, but she also didn't gain back any of the weight. So that means essentially the medication is still working if she's not gaining back the weight, but she's at about what would be expected based on the clinical data. And so her BMI is still in the obesity range. Her waist circumference went down. It's still elevated. Her BMI went down, her A1C went down, but it's still elevated. She was able to stop a medication and her liver enzymes normalized. So she had benefit. She definitely had health benefit, but maybe not as much weight as she would have liked to have lost. So my second example is Mr. J. He's a 56-year-old male, and he has a little bit more significant, a little more severe disease. He has type 2 diabetes and obesity and hypertension and dyslipidemia. He has sleep apnea, gout, NASH, arthritis. He has non-obstructive coronary atherosclerosis. So he's got a lot of metabolic disease, and really the primary focus is preventing future things from getting worse. And you can see with his physical exam and labs, he has uncontrolled hypertension. His BMI is 38. His waist circumference is high, it's 48 inches. His A1C is elevated. He also has a metabolic dyslipidemia, and he has elevated liver enzymes with a FIB-4 score of 2.23, and he had a coronary artery calcification score of 199. So low, but it's present. And he has a long list of medications, including metformin, SGLT2, sulfonylurea, angiotensin receptor blocker, amlodipine, a statin, and allopurinol. So a patient, 56 years old, with a lot of cardiometabolic disease, uncontrolled diabetes. So what's the next step going to be? And this is the algorithm that was recently published from the American Diabetes Association, the Standards of Care. And I wanted to highlight this portion on the right, which is talking about choosing anti-diabetes medications in patients who need weight loss. And I wrote on the left because I know it's kind of hard to see, but essentially what this says is when choosing glucose lowering therapies, that we should consider a regimen with high to very high dual glucose and weight efficacy. So this kind of comes back to the point I was making earlier about obesity versus diabetes, because these medications are effective for both. And so when someone has a diagnosis of diabetes, it makes it a lot easier to prescribe a medication like this, but we want to try to start focusing on medicines that have more than one effect. And so for the efficacy for weight loss, very high was listed as semaglutide and tirzepatide, and then high efficacy is dulaglutide and liraglutide, and then intermediate efficacy was SGLT2 inhibitors. So just wanted to show one slide on SGLT2 inhibitors. We have data showing that they not only do they help with weight loss, but they reduce liver fat and they can reduce liver enzymes. But we have very little histologic data right now with SGLT2 inhibitors. And I wanted to put up one slide on pioglitazone, even though I really wanted to focus on the medications that cause weight loss, because for the sake of completeness, this is a talk about diabetes medications. And we were talking about this during the break, that a lot of endocrinologists and primary care doctors have really sort of moved away from pioglitazone. They think that it's a medicine that's not really needed to be used anymore, but there really are tremendous benefits. And we see really good NASH resolution and prevention of fibrosis progression. but there's additional extrahepatic benefits with pioglitazone, like increased or decreased insulin resistance, decreased lipotoxicity and inflammation, decreased visceral fat, decreased ectopic fat, improvement of metabolic dyslipidemia, and prevention of type 2 diabetes, reduction in cardiovascular disease, and reduction in stroke. So these benefits are seen not just in type 2 diabetes, but also in pre-diabetes. The thing is that the risks are really not as significant as a lot of people make them out to be, but there is this risk of weight gain. The average is 2 to 4 kilograms. But if someone's taking a medication that helps with weight loss, even if they're taking metformin or a GLP-1 inhibitor, the impact on weight is minimal, or if they're on GLP-1, they're usually losing weight anyway. So the other thing that's interesting is that it's the more weight they gain, the better the response to the medication. So it's a little different than the other medications in that the weight loss doesn't predict the benefit. But it's just something that we should all consider for some of our patients. The other risk can be edema. It doesn't cause heart failure, but it's contraindicated in heart failure. And the risk of edema is more if someone is on insulin or amlodipine, and there's a risk for bone loss. But this is something you'd really want to consider in someone who's at risk for bone loss, like someone who's menopausal. The other really amazing thing about pioglitazone is the price. So maybe it's something we should be considering more. But I wanted to move on to the actions of incretins. And so there's 2 incretins now that we talk about, GLP-1 receptor agonists, and now we also have GIP. And the GLP-1 agonist or GLP-1 comes from L cells from the gut, and GIP comes from the K cells. And both of these incretins have a similar effect in that they increase satiety and they decrease gastric emptying, increasing insulin secretion. But they have this combined effect. They have a synergistic effect that really tends to help with appetite suppression and insulin secretion and lowering glucose. And so this is showing the mechanisms underlying the glucoregulatory and weight loss effects of the GIP-1 and GLP-1 receptor co-agonism. And you can see with the dual agonist structure that one compound can affect both receptors and have diffuse effects throughout the body, but especially in the appetite center of the brain and affecting insulin secretion. And this is comparing the 2 studies that were published, both were published in the New England Journal of Medicine, just showing these are the weight loss studies for semaglutide and tirzepatide. And so on the left is semaglutide, and you can see that over a 68-week period, the average weight loss was about 18%. Which was obviously at the time, it was much more than any other weight loss agent. And so that was really, this was considered the first of the second generation anti-obesity medications because of this really tremendous efficacy. And people started talking about how this is approaching bariatric surgery numbers. And then tirzepatide on the right, you can see they have the 5, 10, and 15 milligram doses, and you get the most weight loss obviously with the highest dose, which is getting close to 22 or 23%. And looking at the weight loss categories for sema and tirzepatide, you can see with that over 20% with semaglutide, you've got a fairly high number of people, at least 32% are losing 20% of their body weight. And with tirzepatide, even in that 25% weight loss category, you've got a fair number of people. So it looks like, although these aren't head-to-head studies, looks like maybe tirzepatide's a little bit more weight loss than semaglutide. And this is a head-to-head study that has semaglutide and tirzepatide. But the thing was, this was a diabetes study. And at the time, semaglutide 1 milligram was the maximum dose that was approved for treatment of diabetes. Now it's now 2 milligrams. But it's not a completely fair comparison for weight loss looking at these, but you can see the numbers for the mean weight change is very significant for all of the categories. But again, with tirzepatide, it's that dose dependent. The higher the dose, the more weight loss. And those two that are kind of showing up weight gain, the red, that's insulin degludec, and the yellow one is insulin glargine. So this again was a diabetes study, but just showing the weight gain with insulin compared to weight loss with incretin medications. And this is just showing the improvement in lipids for semaglutide and tirzepatide. From the point to make is that you see an improvement in VLDL, in triglycerides, and in HDL, but it's not much of a change in the total cholesterol or the LDL cholesterol. And this is very similar to other weight loss medications in the lipid study part of it. Just showing some of the data for NAFLD and NASH. This is the semaglutide phase 2 trial for biopsy confirmed NASH, and it did show some improvement in the resolution of NASH with no worsening of liver fibrosis, and also improvement in liver fibrosis by stage. And then the advantage of being able to put together slides at the last minute is that I can put in a really recent article. And I think some of you are in this room who were authors on this study, but this was just showing semaglutide in NASH cirrhosis did not significantly improve cirrhosis or achievement of NASH resolution versus placebo. So that would be interesting discussion to have. My opinion is maybe it's too late at that point, because it seems like the major effect of semaglutide is weight loss. And this was just the one study that's out with tirzepatide versus insulin degludec, showing an improvement on liver fat content. Looking at the cardiovascular benefits, we all know that there's very amazing cardiovascular benefits with semaglutide, and it's just showing improvement in the primary outcome versus placebo of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. There's not as much data with tirzepatide, but this 4-point MACE was looking very promising, and so we are looking forward to more robust cardiovascular outcomes trials with tirzepatide. And then adverse events. The adverse events of tirzepatide and semaglutide are similar, and they're mostly gastrointestinal in nature. By far and away, nausea is the most common, and you can see that it's pretty similar across the different dose ranges. But what's interesting is that this tends to subside with time. And so this is something that if the patients can work through it and can get past the initial side effects, it becomes tolerable as time goes on. The other thing that we find that can be very, very helpful is counseling the patients on what to expect and how to minimize side effects. And really, it's the larger meals that tend to stimulate most of the nausea. So you tell the patients, the way I say it is, this is a hormone that makes you feel full. You will feel full quicker. The instant you start to feel full, stop eating, because if you take even one bite past that point, you'll have severe side effects. And then we tell them also that high fat foods can worsen the side effects. So if they learn how to modify their behavior, it really minimizes the side effects, and then they have the expectation that things will improve with time. And so just finishing up with Mr. J, we started him on tirzepatide, and he was titrated up to the full 15 milligram dose. And he continued most of his other medications, and you can see that 6 months, he had a pretty significant improvement in his parameters. And then at 12 months, even more so, his blood pressure is normalized. His weight had gone down to 196 pounds. We call that Wonderland, when your weight goes from the 200s to the 100s. His waist circumference went down. His A1C was down into the pre-diabetes range. His lipids improved, and his liver enzymes improved. And overall, he had lost 24% of his body weight, so very similar to what the clinical trials are showing. His BMI went from 48 to 29. His waist circumference, A1C, all of those were improved. He stopped glimepiride, and had a pretty significant improvement. So with that, I know that was a really fast tour of anti-obesity and anti-diabetes medications, and I thank you for your attention.
Thanks, Scott.
Okay, thank you, Scott. And I'm going to briefly take us through the treatment for NASH, kind of where we are, state of the art. Let's see. Okay, so treatment, new drugs. So just to set the stage for mechanism, there's many different avenues to treat this disease. And we've learned a lot over the years. I'll show you a slide in a minute on the graveyard for NASH. But ideally, the focus is on treating the underlying milieu or the underlying causes of fatty liver disease. You know, as you know, in liver disease, whether it's Hep C, Hep B, autoimmune, alcohol, if you stop the insult, the liver wants to get better. But parenthetically, what makes the liver better also can lead it down the road to destruction if you don't mitigate those factors that drive the disease. So here you see on the left-hand part of the slide, the majority of drugs are targeting free fatty acid flux from dysregulated adipocytes, as well as modulating de novo lipogenesis or increasing beta oxidation of fatty acids. All three of those are the main proponents or the main bad actors in how you get excess toxic fatty acids into the liver. It's also important to note that the liver wants to deal with these toxic fatty acids very quickly. And the majority of the way that this is done is through esterification of the fatty acids into inert triglyceride and stored as steatotic droplets in the liver. We pick that up by MRI-PDFF. So as we go through treatment, some of the discussions that I've heard around the industry are, if you're not moving PDFF, you're therefore not working as a drug. And I just want to at least give my opinion on that right up front, that I don't believe that's true. Moving inert triglyceride doesn't necessarily improve or decrease inflammatory mechanisms or activation of stellate cells. It's the collinearity of reduction of the toxic fatty acids that we can't measure routinely in clinical practice without doing lipidomics. So the regulatory framework for drug approval hasn't changed in more than a decade. For conditional approval, that means you can begin to sell and market your drug. You have to have a histopathologic endpoint, but for full approval, you need to go on and show that you have an impact on outcomes. So right now, for that Subpart H approval, NASH resolution without worsening of the underlying features of steatohepatitis or fibrosis improvement of at least one stage. So those are the two ways: NASH resolution without worsening of fibrosis or fibrosis improvement without worsening of NASH. So along the way, we've learned quite a bit. These are representative drugs that unfortunately did not make it across the finish line. And I have the dubious honor of working with all of these but one. So as Michael Jordan said, we learn more from failure than success. I think we've learned a lot about drug development in this field as a result of some of the lessons that we took away from these drugs. I don't have time to go into what those lessons are in this 20-minute talk, but there are a lot of those that we now apply with our new studies and the way we look at drugs today. So I want to speak about the agents in phase 3 development first. There are currently 4 drugs that have made it through the end of phase 2 and at least have launched into phase 3 or had a discussion about launching into phase 3. Ramcol is an SCD inhibitor that while it has completed a phase 2 trial that was positive, it has not moved forward yet into phase 3. So with that being said, those are the oral agents on the left, and the injectable that is in phase 3 for NASH right now is semaglutide. So the 4 drugs you see there are where we're at. I want to briefly take you through each of those. Resmetirom is a thyroid hormone receptor beta agonist. It's pleiotropic in its effects in the liver, It mainly works through improving mitochondrial health, and in so doing revs up beta oxidation of fatty acids. And preliminary data from the phase 2 trial showed that it lowered liver fat, potentially reducing lipotoxic stress, improving NASH resolution, lowering LDL cholesterol and triglycerides. And just parenthetically, just to think about NASH patients and what happens in the liver, there's a relative hypothyroidism. You're unable to convert T4 to T3, so you get a buildup of reverse T3. There's a very nice correlation between the amount of reverse T3 and the severity of underlying liver disease. So in effect, the THR beta class of drugs resets the liver's ability to convert T4 to T3. So it's a complicated phase 3 program that resmetirom has undertaken, and I want to just walk you through this very, very succinctly. So there were a total of 4 phase 3 trials done for this drug after the initial phase 2 data. The first one that completed was the Maestro-NAFLD-1 trial. This was a non-invasive test to get in. It monitored non-invasive tests along the way, and its primary endpoint was safety and tolerability. So no liver biopsy to get in, no liver biopsies were done along the way. Over 1,200 patients were enrolled and treated for 52 weeks. And this paper is now in review currently. Now, if you completed 52 weeks of therapy in the Maestro-NAFLD-1 trial, you were offered the opportunity to roll over into the open label extension trial, what we affectionately call as MAD-18. More than 700 patients did roll over into this trial. Again, it's looking at additional 1 year of safety and tolerability, although additional non-invasive tests are being done out to the 2-year time point. This trial is currently still underway. And then Maestro-NASH, this is the Subpart H approvable or the regulatory trial that recently wrapped up. This paper has not come out. We did present, a press release was released on December 19th relative to the data, and we presented the first top-line data of this at NASH Tag in 2023 this year. And we'll talk a little bit more about that. More recently, there is a well-compensated F4 population of patients called Maestro-NASH Outcomes that are currently underway and enrolling. The plan is to enroll about 700 patients, well-compensated F4s, using historical biopsy back to 5 years for about 70% of the cases. About 30% of the cases can get in using non-invasive tests alone. This is an outcome-driven trial. The plan is not to repeat liver biopsy or do liver biopsies down the road in these patients, but just follow them out to a non-invasive outcome. Along the way, non-invasive tests are also done here. Corporately, the goal is to have achieved a large enough safety database to file a new drug application with the FDA for the use of both doses of drug 80 and 100 milligrams. The phase 3 results from the Maestro-NASH trial that were pressed in December and originally presented at NASH Tag are shown here. This is intent to treat analysis in 966 patients. And you can see that it hit both regulatory endpoints, NASH resolution on the left in a dose response manner with a roughly 20% treatment effect delta relative to placebo for NASH resolution. And on the right, 1-stage improvement of fibrosis over placebo here, around a 12% treatment effect delta. A key secondary endpoint is on lowering LDL cholesterol, and very nice reductions for both doses, achieving around a 16% reduction with the high dose. So moving quickly to obeticholic acid, this is an FXR agonist. It's also pleiotropic in mechanism. It blocks CYP7A1, the rate-limiting step that converts cholesterol to bile acids. It also inhibits de novo lipogenesis and has effects on fatty acids and lipotoxic stress, ultimately culminating in reduction in inflammation and fibrosis. Here you see the phase 3 trial results. On the left are the original analysis that was previously presented and published. This was also the analysis that led to the first new drug application that was filed. And you see that the treatment effect delta for improvement of fibrosis by at least 1 stage of around 11 to 12%. Now, on the right, this was more recently done. It's consensus methodology. So the difference between these two reads are simply the way the pathologists read the slides. On the left, you had two pathologists read each of them half of the slides independently, and the data was put together. They did not reread each other's slides. On the right, you see consensus methodology, which has now been presented and I believe published, where each three pathologists read all of the slides independently, and where two agreed that was what was taken forward as the final read. And you'll see this has gained in popularity. More and more trials are shifting to this consensus read methodology, and quite frankly, it makes sense. But ultimately, the data is very similar. The treatment effect delta between high dose and placebo is again around 12% or so. Same patients reread in the second consensus methodology read that you see here. And just one more comment there, the new drug application was also filed late last year for a second time, and the PDUFA date, I believe, is the 22nd of June with an AdCom scheduled for May. So lanifibranor is a pan-PPAR. It has PPAR alpha activity similar to what fenofibrate has. It has PPAR delta activity. You guys know PPAR delta from the seladelpar days. Seladelpar no longer being studied in NASH, but being studied for cholestatic liver disease, but also has impactful effects in the setting of NASH, as was noted by the very large phase 2b trial published or presented on seladelpar showing effects on histopathology. Parenthetically, it did not move liver fat. So a pure PPAR delta agonist does not move MRI-PDFF, but has underlying effects on serum liver chemistries and histopathology. And then we know about pioglitazone, so this also has PPAR gamma activity. This is the phase 2 trial published in New England Journal by Sven Frank and colleagues. This used the SAF activity score rather than the NASH CRN score. The primary endpoint was a reduction of at least 2 points in the SAF score and no worsening of fibrosis. And you see statistical significance with the high dose versus placebo. But on the two key secondary endpoints, which are the registrational trial endpoints used by the FDA, there was statistical significance also for high dose versus placebo for fibrosis improvement, and then for both doses for NASH resolution. And based on this data, this drug has moved forward into phase 3. Interestingly, in the phase 3 trial, the treatment duration is 3 times longer than what we saw in the phase 2 trial, which was 24 weeks. In the phase 3, it's 72 weeks. So semaglutide, we've already heard a lot about, the GLP-1 agonist. I won't dwell on the mechanism. Just to show you the phase 2 results, I believe Scott showed also. On the left, primary endpoint was resolution of NASH with no worsening of fibrosis. It hit that with the high dose versus placebo, 59 versus 17%. There was not a dose response there. However, when you went to machine learning and you used AI digital pathology, there was a very nice dose response with this particular trial. And in fact, the placebo response rate was cut in half as well. So just thinking about lessons learned for the field, using AI digital pathology to augment your ordinal scoring, I think is very important to understand truth about how effective your drug is. Secondary endpoint on fibrosis improvement was not met. Just a couple comments about an up and coming mechanism of action that has not made it into phase 3 yet. However, will soon be in phase 3 later this year. And this is the FGF21 agonist class of drug. We'll hear more about that throughout the week. But efruxifermin is the first drug that's really shown a benefit in NASH. It's not the first drug to report in this field on biopsies. That was Bristol Myers Squibb pegbelfermin, which is a pegylated FGF21 that did not show a benefit. I think it's important to note that all FGF21s are not created equal. It really depends on their chemical scaffolding. Efruxifermin is a covalent molecule of 2 FGF21s that are linked together with 3-point mutations that allows it to stay on target for a longer period of time. There is a marker of target engagement for this class of drug. It's adiponectin expression, which should be upregulated significantly if it's impacting the underlying disease. It's pleiotropic. It works through beta-klotho FGF1, 2, and 3C, with 1 being adipocytes, 2 and 3 working in the liver. So it's important to understand when you're talking about different FGF21s, where your particular target is. So the phase 2B results, this is called the Harmony trial, have not been published yet. This was presented at AASLD last year. Both doses, the 28 milligram and 50 milligram dose, achieved statistical significance on the primary endpoint, which was fibrosis improvement. On the left, you see a treatment effect delta for the high dose of around 21%. And for NASH resolution, 76% for the high dose, 15% for placebo. It's also important to understand that in phase 2 trials, you see a wide variation in placebo response rates. This tends to stabilize a bit in the phase 3 trials. Phase 3 trials for NASH resolution somewhere in the high single digits, and for fibrosis improvement in the low double digits. You get a wider variation in phase 2. Lots of reasons for that: smaller treatment numbers, shorter treatment duration, and also the methodology is changing a bit. Some of these phase 2 trials still use single readers or double readers that don't harmonize between the two. I think we're getting towards a better outcome by using consensus. It's also, let me back up and just mention, well, I can't back up, but I'll also mention a press release that came out yesterday for 89 Bio, which is a glycopegylated FGF21, showed very good results, very positive results in their 24-week primary endpoint study on both NASH resolution and fibrosis improvement, as well as the composite. Very nice results on extrahepatic benefits relative to triglyceride lowering, glycemic control, similar to what was shown with the efruxifermin. PXL065, this is just a touch on this briefly. They completed a very large phase 2B trial with treatment duration of 1 year. We presented this at AASLD. The idea being, we like pioglitazone, we don't like the side effect profile. Can we mitigate the side effect profile and just take the good portions of pio forward? Through elegant work done by chemists, you're able to separate out the S and the R enantiomers of this compound, with the S being linked to the side effect profile. So if you could get rid of the S and take 2 R enantiomers combined with deuterium, potentially you can double the benefit without having any of the risk. And just to show one slide on the phase 2 results, did not hit on NASH resolution and didn't quite make it on fibrosis improvement. You don't see a dose response relationship, but at least at the 15 milligram dose, there appeared to be a biological activity on fibrosis using this mechanism. So just give you, this is just my perspective. Please don't take away anything other than that from this, but I wanted to give you my idea of the drugs in phase 3 and the drugs that have completed phase 2. I don't have 89 Bio here because the data just came out yesterday. First, on safety and tolerability, it's important to take this with a grain of salt. When data is published in the literature, usually what you see on treatment emergent adverse event profiles is a lot of mild and moderate grade 1 and grade 2 effects. And there's a lot of, thought given to whether you call a side effect grade 3 or grade 4. But we know that occurs. We enroll a lot of patients with NASH, and a lot of times we see that happen. So in green, I put where I feel like the data is best for safety and tolerability, and that's on 2 oral agents, resmetirom and the Poxel drug PXL065. The rest of them I give a kind of an orange nod to. Most are mild and moderate side effects. Some we know well. The GLP, any injectable that's used in NASH is going to have GI tolerability issues, nausea, diarrhea. But patients I saw yesterday in clinic all complained of constipation on their GLP-1 or GLP-1 GIP. So can't forget about that either. So I just put this together for thoughts about what are the major components of what we want a NASH drug to do. And I hope we have a discussion about that in the next few minutes. But I have fibrosis improvement, NASH resolution, insulin sensitivity, and lipid benefit because of the cardiovascular disease associated here. And I'm just going to put the drugs where I feel like they're working the best. So lanifibranor is that pan-PPAR agonist. It does appear to work well on fibrosis in phase 2, NASH resolution, and as well as insulin sensitivity. However, its lipid benefit is lagging a bit. It is oral and it's once a day. Semaglutide is an injectable. You see it over on the right. It has positive impacts on insulin sensitivity, glycemic control, weight loss, and NASH resolution, but it does not have a lipid benefit, and its fibrosis benefit has also not been shown. PXL065 so far, based on the phase 2 data, potentially beneficial in fibrosis and insulin sensitivity. It's oral and well tolerated. So down the road, if we're looking at combination therapy and you need a drug that moves insulin sensitivity and may give you additive fibrosis benefit, potentially this is a drug to consider. Efruxifermin, again, an FGF21 agonist, it's injectable. It hit on all 4 of these. You can also say the same thing for 89bio's drug, pegozafermin. Resmetirom, oral once a day, hitting very nice results on NASH resolution and fibrosis improvement in phase 3, and a very good lipid profile. It does not have any impact on glycemic control or insulin sensitivity. So it is a single therapy enough? Not likely, in my opinion. We're trying to target fibrosis improvement and NASH resolution. But again, thinking outside the box and not trying to be myopic, as a hepatologist, we need drugs that reduce lipotoxic fat, weight loss, atherogenic lipids, and glycemic control. And so it's unlikely that a single drug given for the long haul could be sustained to target all of those. And so ideally, I think we need combination therapy that will synergistically improve histopathology as well as enhance long-term outcomes. And this is Mike Charlton's slide. I use it over and over again. He showed this at NASH Tag a couple years ago. This is the Jamaican 4x100 meter relay team, set the world record in Seoul in 2011. And I think this really typifies the ideal combination therapeutic regimen. We all know Usain Bolt on the right set the world record in the 100-meter dash, but he could not have run the 4x100 meter relay alone. He needed 3 other compatriots. What was similar about them? They were all world-class sprinters in their own right. They got along well with each other. They had complementary strengths and similar endurance, which I really think sets the tone for what combination therapy should do. Just to give a flavor of where we are with combination therapy, this is a GLP-1 combined with an acetyl-CoA carboxylase inhibitor that works on de novo lipogenesis and an FXR agonist put together in a clinical trial. And this is the results at week 24, first showing weight loss. And compared to Sema on the left in the light blue, not a lot of additive effects on weight loss. Okay, so that combination is not really doing anything there. However, same trial, same set of patients, there is a bigger impact on liver fat content reduction. So this is just one of the non-invasive tests that were looked at in this trial, showing the potential benefit of combination therapy. So I'll wrap up with where we are headed. In addition, I think we're really getting to where we can begin to talk about precision medicine to attack fibrosis. There's CAR T therapy. I see Scott in the room today. He actually was part of this trial published in Nature in 2020, looking at targeting senescent stellate cells. And when you're able to do that using CAR T therapy, there was a significant impact in an animal model on fibrosis as well as liver chemistry tests. Where we go with this relative to NASH in humans, I'm not sure, but it is provocative nonetheless. Targeting the gut microbiome still has potential benefit, as you see studies underway here. And then genetic polymorphisms, the biggest ones we are now studying to try to modulate are PNPLA3 and HSD17 beta 13. And we can do that in a number of ways using potentially therapeutic oligonucleotides, antisense oligonucleotide therapy. So there's all this happening in addition to the drugs that are being developed that I've already mentioned. So with that, let me thank you for your attention and invite my colleagues up to the stage for a robust debate in a minute. All right, come on up here. Okay, so we don't have a lot of time, but I want to open it up to comments. It's great to see we already have a couple of folks at the podium or questions. Why don't we start?
Okay, Norman get there. So I was perturbed with the results that came out with resmetirom, that the placebo result was 14% and the delta was only 10%. I think if I were the company, I'd take all the placebo studies and get a consensus histological interpretation and see if that could reduce the placebo rate, because a placebo rate of 14% is astronomical. And as I said, the delta rate is only 10%. Thank you.
Yeah, I think we've talked for a long time about looking at the placebo response rates of these drugs. And, you know, it's interesting that the way that we get at determining the primary endpoint that the FDA is requiring is histopathologic. And the paper that Beth Brunt published with Quentin and many of us looking at the ballooned hepatocytes and the fact that they could only agree on 1 out of 1,100 tells a very good story. And this is, we're all pushing to move away from histopathology as that endpoint, but there's a lot to placebo response rate beyond just, you know, what you do in clinic with lifestyle modification, with the drug that's being studied. And it's something that we need to look at more carefully. I don't know if you guys have any thoughts on placebo response rate, Rohit, or
yeah, thanks, Norman, and thanks, Stephen. Placebo response rate, I think, is important, but the one beautiful thing is, at least in randomized placebo-controlled trial, that hopefully the assessment of the treatment and the placebo, the way randomization is working, is able to account for whatever the differences are within that trial. So I completely agree with you, Norman, that you can't take placebo response from one trial and then build it into another trial and compare what their treatment effect delta would be. But I also agree that you could definitely improve precision around the estimates, but the treatment effect deltas don't lie. And as Stephen showed, the consensus read model could really improve the precision of treatment effect delta. But the issue with the placebo responses would remain, and they will get accentuated as we go into higher stages of disease. So you go into cirrhosis trial, that's where the placebo responses are going to be even bad if you're looking at regression of fibrosis as an endpoint. And if you've seen that across the board in cirrhosis trial. But luckily, within the same randomized placebo-controlled trial, if you have enough patients on placebo, the treatment effect delta don't lie.
Yeah, and I think we see that in the phase 3s, right? Where the treatment effect, placebo response rate on NASH resolution and fibrosis is again, single digits for NASH resolution and low double digits for fibrosis, and much more variable in smaller, shorter term trials in phase 2. Zubair. Oh, okay.
Sorry, no, Roma from Siemens. Hi. So I have a question for the panel on the results of some of these drugs that are already available. For example, liraglutide for weight loss, and what you see after the patient has achieved goal weight and ceases taking these drugs. There's starting to be anecdotal reports of a large amount of weight gain afterwards. So what are you seeing? And then is there an effect of those patients who have adopted lifestyle change in addition to the drugs versus those who have not?
Scott, you want to start? Now it is.
That's a great question.
Nope, it's not working. No, that was Scott.
Is this one working? Okay. Okay, that is such a good question. Thank you for that. This is an issue that we see all the time because of the fact that these medicines are so expensive and that they have side effects and that people do want to discontinue them. But these drugs are approved for chronic use. So the idea is not to discontinue. And there is data showing that when a GLP-1 medication is stopped, within 12 months, all the weight or most of the weight is regained. And so it just, again, goes to show that, the medicine is only working when it's taken. And so there's a weight loss phase and then there's a weight maintenance phase, but weight maintenance is the most difficult part of weight loss. And so these medications
are great for that. The reality is that people do stop them. Their insurance changes, or for whatever reason, they have to stop them, or they want to reduce the dose. And so we're kind of in uncharted territory. Some of these patients work really hard and they keep off the weight, in my experience. Other patients, we've tried reducing the dose and they've been able to maintain the weight. So I think it's individualized and it's customized, but there's really no good data to support stopping these medications.
And just to add to it, that it emphasizes, actually the question emphasizes the importance of lifestyle modification, structured programs for lifestyle modification for people who take these medications.
So Bear.
And two questions, just actually one was related to this, because even with the combination, you can achieve sort of an efficacy potentially after, say, a year or a year and a half of treatment, then you have to maintain that. And I think in order to be cost effective for screening or for treatment of something, you're going to have something that would be, that would be manageable in terms of not only side effect profile, but also cost long-term. And maybe that's the personalized medicine that after a year and a half or so that you could go to a lifestyle modification that can actually be maintained. The maintenance part of it is the key. This is not like hepatitis C that you can treat for 3 months and go away. This is going to be like, diabetes and dyslipidemia that we have to treat for life. The other question that I have, and actually this is for Rohit and Steve, for you, we've focused on fibrosis improvement and NASH resolution. I mean, these are really ultimately surrogate of outcome, because you can't do outcome studies for clinical trials, obviously, to get approval, at least in the initial, subpart part of it. But how about getting more serious about NIT validation for long-term outcome? Because if you're going to push away from biopsy, then our NITs have 1 year follow-up or 2 years follow-up. Then it just doesn't make a lot of you can't really make the argument that NITs could then predict outcome, because that's ultimately what we want to do. It's just not to change a number, but actually improve either quantity of life or quality of life.
Yeah, that's the elephant in the room, Zobair, on the NITs. So maybe I'll take a stab at it and you can clean up my work, Rohit. So, the NIT, there's a lot of work being done on this, looking at outcome measures. Rohit has Goldmine. It's going to be looking at this. We're looking at it through NAIL NIT that Mazen and Naeem are leading. There's also Litmus and Nimble, although Litmus isn't so much looking at long-term outcomes. We have 2-year follow-up on some of the MRE data and maybe looking at trying to extend that out a bit. But that's the holy grail. I mean, we don't want to necessarily compare an NIT to a surrogate of a surrogate, right? So we don't want to compare necessarily an NIT to a biopsy, which then has to be compared to outcomes. We would like to go straight to outcomes. And, that takes time to generate. And outside of clinical trials, and outside of the NASH CRN, there's little data where we have that ability to do that. So whether it's Regenerate, there's patients been on drug now for 8 years in that particular trial, as you know, and Maru and others. And Maru's led the publication, I believe, in JHEP, right? We're looking at outcomes or looking at NIT change over time. So we just need to mine that data. Same thing with the Maestro studies. Mine this outcome data over time. I can tell you that just having come from an end of phase 2 meeting with the FDA this week, they're reticent still to make that change, to jump to an NIT without more data. I believe that there's a lot of data we've generated on NITs with outcomes, but we haven't really combined that data. So there's a publication here, there's a publication over here, but we haven't really synthesized that data. We haven't done independent patient data meta-analysis on that data. And I think there's a lot of work we could do that we haven't done to drive the FDA towards a data-driven decision to switch to NITs. But love to hear your thoughts, Rohit.
Thank you, Stephen. I completely agree with you. And I think we all would have to work together, especially the investigators and the various companies and stakeholders. If you have NIT data, I think let's work together and pool it. We need prospective studies. And, one of the prospective studies that Stephen, Naeem, Alina and I and several others are doing together is Gold Mine, in which we have baseline MRI, PDFF, baseline MR elastography, both 2D, 3D, liver stiffness assessment by other modalities, including FibroScan, having baseline serum-based fibrosis markers, potentially ELF, PRO-C3, and then every 2 years, patient come back for repeat assessment on non-invasive tests, and baseline they have a biopsy anchored to it, except in those with cirrhosis. We are already accumulating outcomes. We have now 500 patients in Gold Mine. And you can see the study started many years ago. We have 0 publication, but that's the intent, that we want to bring things out when they're mature. But I think this would be the year we'll start looking into those with central MR-based assessment, central histology reads, and then all the biomarkers will be coming out. So hopefully we will be able to replace the need for biopsy in registrational trials. I would give a lot of credit to Maru and also the writing committee for the ASLD NAFLD practice guidance. They really inspired us to put in a table of how can we predict treatment response. And we have initially put in, how can you detect at-risk NASH? But I think it's built into that, how we can predict treatment response. 2 things we put in is, MRI PDFF based upon some of the data that, you've looked at, Mazen has looked at on resmetirom with FGF21s. I think it's clear if you get a 30% MRI PDFF reduction, you have 5 times higher odds of NASH resolution. So that's one piece of the puzzle, but it's not going to solve all the problems. Then Daniel Huang added MRI PDFF plus the ALT response based upon our work from Flint with uricolic acid. That 17-unit ALT response. So you combine both of them, now you're looking at odds of NASH resolution 7 times higher. Again, when you convert that into an ALOC, it's still pretty low, it's 0.7. But I think we're building the case, and as we go forward, we may have better predictors of treatment response. Another, based upon your work, Zubair, and your work, Stephen, pooling SIL-Dip data in 4 randomized placebo-controlled trial, it's clear that disease progression can be predicted on liver stiffness. So what is a clinically meaningful increase in liver stiffness? On FibroScan, 5 kilopascal increase plus a 20% increase. What we don't have is what is a clinically meaningful decrease in liver stiffness, but potentially we can get that. And same thing with Alina's paper, 1 kilopascal increase on MR elastography being clinically significant. But if we could have a pivot in terms of reduction associated with a clinical outcome, and that may happen in 2-3 years.
Yeah, Zubair, we could go on and on. There's lots of great comments, lots of great questions. I know we're a little bit past time. I want to give Alina and our good friend here another opportunity to ask some questions. I do want to just add to your comment on FibroScan. So we are beginning to at least get bits of data linking a reduction in FibroScan by kPa to histopathologic improvement. We know with resmetirom, a 3 kPa change actually is associated with fibrosis benefit and NASH resolution in the phase 3 trial. And then also with the 2 FGF21 compounds coming out yesterday from 89 Bio, around a 3 kPa reduction with Akero, a 4.7 kPa reduction linked to fibrosis benefit. So somewhere between 3 and 5, I think, is where we're going to begin to see a number that resonates. Alina.
I'll make it short. Questions for Shira, switching back to lifestyle nutrition specifically. We talk about the red meat consumption in association with fatty liver disease, and I try to put this into context in clinic when I see a patient with NASH cirrhosis and sarcopenia, where we advise them to increase their protein intake, and then they go back to the meat question. Are we convinced, based on the evidence, that the red meat consumption association with badness is not related to confounders with carbohydrates that associate those meats? Do you know of any data that adjusts for that?
Usually most studies adjust for BMI and other dietary factors. So usually the associations are adjusted. Now I show just one study, my study, but there are actually other studies by other groups showing repeatedly an association between red and especially processed meat and NAFLD. They do not refer specifically to the cirrhotic patient with sarcopenia. So generally to NAFLD patient, you don't say to avoid meat, but you recommend not above 1 or 2 portions per week of red meat, unprocessed. And processed meat, the recommended recommendations today, even of the WHO and other associations, is to not consume at all. And if you consume, then not more than 50 grams per week. So very small portion per week, or 0 is even better. For the cirrhotic patient with sarcopenia, actually, red and processed meat are not the best. You can recommend poultry. You can recommend dairy products, which are very good source of protein. They can have an egg a day, which is very high quality protein. They can have legumes and soy products if they want to. So they do have other very good sources of protein. They don't necessarily need to eat red and processed meat. Thanks.
You're up.
Thanks. Thanks, Steve. I enjoyed your talk, all of you, but Dr. Isaacs, I enjoyed yours as well and appreciate the ad hoc nature of the effort you went to. I've been rather amazed by the number of patients in my practice. I see NAFL patients every day, sometimes it seems like all day, who've gotten tirzepatide prescribed by other physicians. I haven't yet prescribed it. Generally, I leave it to my primary care colleagues or endocrine colleagues to prescribe the GLP-1s anyway. And most of these patients have not been diabetic, so they're getting it off label at this point. And I've been struck by the efficacy of the drugs. The patients comment with particular enthusiasm that I haven't heard so much with the other drugs about the degree of weight loss they've experienced. And in a couple of cases, patients who've taken semaglutide have compared the side effect profile of tirzepatide favorably to the drug they took before. I don't know if that's just a matter of the numbers so far, with so many more patients having taken semaglutide, but I just wonder if you can comment on your personal experience.
My experience is very similar. And one of the things that's been really interesting with both of the new drugs, with semaglutide and tirzepatide, the media, the popular effect, the social media effect that's on TikTok and Facebook and everywhere. And so this has really become, in my practice, people come in asking for these drugs by name. And so we have the data for using tirzepatide for weight loss. And so it has been prescribed a lot off-label, and the efficacy is there. And so I think the issue in the very beginning is it was really easy to do. They had a coupon that you could use it, pretty much anybody could use it, and that's gone away now. So not as many people just taking it like it was. But you also have a really good point about the side effect profile, and anecdotally, I mean, I've seen the same thing, fewer side effects. The GIP may have an anti-nausea effect, and that may be reducing the side effect. There also seems to be this effect. People say they have this, they feel better, this enhanced sense of well-being, whether that's because they're not stressed about food or for some other reason. I hear about decreased cravings for alcohol. They get along better with their teenage child, and so we hear all these benefits. So how much of that is just because they're not as hungry, and how much of that is something else, I don't know. But it does seem to have a lower side effect profile.
Yeah, I have great comments. Thank you. I have one final question as the moderator. I'll take that provocative and ask Shira. So you talked a lot about exercise, kind of. It's the first time I've seen you kind of add a lot more data around physical activity to diet. Kind of one comment and then a question. There's a recent paper out in Nature Medicine on using step count, 8,200 steps, I believe was the number, that showed a significant reduction in all-cause mortality as well as rates of progression to diabetes, obesity, even Alzheimer's, anxiety, depression. Is that something we should be advocating to our patients to advocate a particular step count number in addition to lifestyle dietary changes? And then the second question is, I didn't see you comment on anaerobic activity. So lifting weights, building lean body muscle mass. Two quick replies.
Okay, thanks. So for the first one, yes, absolutely. I actually recommend my patients to do that. And we have the step count, and I ask them to show me their step count. It's a very good way to make sure that you're physically active. The minimal amount is usually 10,000 steps. And of course, if it reduces morbidities that are strongly related with NAFLD, of course, we should recommend it. Specifically, the studies I've shown were following the usual recommendations of 150 minutes per week of moderate physical activity or 75 minutes per week of more vigorous physical activity. But of course, the step counts is also another way to do that. As for a resistance anaerobic or a resistance exercise, there are some studies showing that it is also beneficial, maybe a little less than aerobic exercise, but generally, if you do resistance exercise 2 or 3 times a week, about 40-45 minutes per session, then you get liver fat reduction. We don't have evidence though about NASH or fibrosis. And of course, the best thing is to combine the 2 types of exercises. You get aerobic effect and you get the resistance exercise to also to increase muscle mass and to treat sarcopenia, which is very common in NAFL patients.
Excellent. Well, Scott, you commented about TikTok. We're going to turn it over to the TikTok liver doc, Naeem Al-Khoury, who has a Twitter handle and among many other attributes that he brings to the table. So he's going to moderate the next session and look forward to having you and hearing more about NITs. Thanks.
All right, well, thank you, Stephen, for the introduction. So Naeem Al-Khoury from Arizona Liver Health. I just want to thank the organizers for inviting me to moderate the next session. We're going to hear about the use of NITs and clinical care pathways to identify at-risk NASH patients. Our first speaker is my dear friend, Dr. Mazen Nuruddin. He is professor of medicine at the Houston Methodist Hospital. He is also the director of the Houston Research Institute. Mazen has been leading the way in developing non-invasive tests to identify high-risk patients, and this is the topic of his talk. So he will tell us about risk stratification for NAFLD algorithms using NITs. Mazen.
Gosh, man, I always get here. Anyways, good afternoon. I'm holding you from lunch. I would like to thank the CLDF for bringing us for the cold part of the country. We all came from New York, Houston, other places, and much warmer. So I'm going to talk about a topic that is close to my heart, which is the non-invasive test. I'm not anti-biopsy, but we have too many patients, millions of people around the world. We cannot just go biopsy everyone around. And we have made a great advancement in the field. Those are my disclosures, much less than Stephen Harrison. So this is the natural history of non-alcoholic fatty liver disease. NAFLD with the D is the big umbrella of the disease. Then you take out the D, it's NAFLD, which is what he used to call simple steatosis. And then you get NASH, and then fibrosis, cirrhosis, and hepatocellular carcinoma. The reason why this is important because we need to understand how we got there. We got there with biopsy results, telling a lot about the histology, educating us that has been made a great progress. Nevertheless, over the time, we came up with NAFLD and then NASH, and we started studying it. And when we found this second hit hypothesis, now it's called multi-hit, we said, this is where is the problem. We have NASH, NASH can lead to fibrosis. Let's treat all NASH. And many people, they were like, well, you cannot treat 16 to 20 million people. So we started looking over time, who can get to morbidity and mortality. The question came out as, which group of population they will die from liver disease? And this is when we started understanding more about the disease, where at stage F2 and higher, patients are more likely to have morbidity and mortality, liver transplantation, and death. So that's why I have these two red boxes. The box number one is, this is the focus in industry for phase 3 study, NASH and F2 and higher, because those are the group that they need pharmacological therapy. Of course, we're going to treat the entire spectrum. We're going to try to get rid of earlier phases of NASH as well as NAFLD, but weight loss and exercise maybe can do that on their own. Cirrhosis is a different beast. We have the NASH cirrhosis ETC by the ASLB happening next. So I invite you to that, but it also has been very difficult to treat this group, and we expect a lot of failures, and hopefully we have a drug for the NASH cirrhotics. So I'm just showing you the data that we built on. This is the most recent systemic review in gastroenterology, showing you the story that has been going on for the last decade or so. Things Zubair started this finding with NASH and F2 and higher, and then multiple publication from Rohit Graves, and then meta-analysis showing at the F2 and higher, you have correlation with morbidity and mortality. So that's key for the disease. Now, the New England Journal study that came out now 2 years ago, what it showed us, this is the NASH CRN data. It's a prospective data that collected patients for many years. And what they found is that patients at the F3 and F4 level are those that they correlate with morbidity and mortality. Importantly here, they lump the F0 and F2 together. And many people start saying, well, maybe we should then start treating at the F3 and higher, not the F2s. And this is that was my analogy for this finding. Do you really want to go to the exam just with 1 or 2 day preparation? That was me in medical school. It was not a good idea. So you really want to start preparing way earlier than that. And this, we have enough data at F2 and higher that shows you like cause for morbidity and mortality. So the treatment should start then. So start a little bit early and give yourself a room for that exam. So context of use. Let's talk about NITs. My goal here, like the NIT field has really exploded, but there's a lot to be done. But I want to summarize what's in the literature, and I want to tell you about the guidance that Model led recently, and I thought it's pushed the NIT to a different level, especially to use them. So context of use, we started when we learned about fibrosis. We said, well, we can actually detect fibrosis without a liver biopsy, so let's do that. So there's the FIB4 and others. But also because NASH is the driver of the disease, and the phase 3 trials focus on NASH and F2 and higher, we started looking into this population of NASH and F2 and higher. So the first step is staging, knowing what your patient has, knowing fibrosis, and now we're digging deeper, which I call it second generation test, looking at NASH and F2 to identify those that need therapy. This is monitoring therapy. I apologize, this is translation from Apple to Windows, but there are little data on response to therapy using NITs, and I will show you and talk about some. And finally, and most importantly, correlation with outcomes. And correlation with outcomes is a key feat. I always say, no matter what's the context of use, you need to keep your eye on the prize, which is you need something to translate into patient outcome and tell you the story about these patients. Actually, the FDA and EMA, in order for them to replace liver biopsy with NITs, that's what they all focus on. Does your NIT predict outcome? Does it, if it worsened, does it, is the NIT worsened, do you get outcome? And if it improves, does it move you away from the outcome? So we have multiple guidelines now. This is the American Association of Clinical Endocrinology. Scott was the lead on this, and the story is consistent. And I think as of today, if a patient walks in a doctor's office with especially gastroenterologist, with type 2 diabetes or 2 metabolic risk factors and does not get staged, I don't want to say this is malpractice, but it is not a good medicine, because we know that disease is prevalent on this population. We know that they get higher fibrosis, and now you have guidance after guidance telling you that type 2 diabetes or 2 metabolic risk factors, you should screen. And the study was made simple, and luckily, society guidance all agreed on what to start with, and this is the FIB4. So the FIB4, I will show it to you in a second. Most people here know what's the FIB4, and values less than 1.3. The patient stays with the doc, primary care, and work on lifestyle intervention. Levels between 1.3 and 2.67. This is indeterminate, and you need further classification. And then more than 2.67, that's most likely advanced fibrosis. Now, previous guidelines, and this is what I like about the ASLD. Like, I'll give you an example. I mean, more than 2.67, if it lands in any hepatologist office, we don't stop there. We say this patient has F3. We do more, and I'll show you like what the ASLD guidance did this time. EASL guidance is also consistent with the ASLD with a little bit variation. They all recommend starting with FIB-4 followed by transient elastography. This is the AGA clinical pathway. Same story. Type 2 diabetes and 2 metabolic risk factors. You get the FIB-4. After that, it depends where you're at. You get transient elastography if you are in the indeterminate zone, and if you are on the 2.67, you're being referred, and you're going to get more at the specialist. So this is where the rationale came for diabetes and 2 metabolic risk factors. So this is the 10 metabolic risk factor. A paper came from Baylor showed that if you have 2 traits or 3 traits or 4 traits, your odds and hazard ratio of getting cirrhosis or ACC increase. So it was ethical thing to do to go after these patients with metabolic risk factors. Make a lot of sense. Maro and I and others in this room put this paper for gastro looking for cost effectiveness of type 2 diabetes. We actually worked on this paper for almost 3 years, but the old guidance by ASLD, they said there's no cost effective papers showing that screening diabetics is beneficial. And we took that exercise built on the biliary analysis data and Markov model, and we showed it's cost effective by just doing weight loss and exercise. So now it's implemented in many guidance that this is cost effective to screen for type 2 diabetes. Let's start simplifying things. And I'm sorry if I'm throwing the NAFLD fibrosis score out, but now like the consistency is with FIB-4. These are the cutoff value that I have been talking about. So I always tell people just to try to remember the FIB-4, which is most commonly used. Now there's a problem with FIB-4, as you know. It might not perform as well in type 2 diabetics and age 65 and higher. So always keep this in mind. And age 65 and higher, you have to move the threshold a little bit higher. So keep an eye on that. I think in the future, I like the FIB-4. It's cost effective. It's easy to do, but I don't think we're done just by saying if FIB-4 is the test. It might change in the future for easier test, more straightforward. I mean, we have machine learning, we have AI. So leave the door open for these NITs field. So this is the age 65 and type 2 diabetes. Transient elastography, you all know it. There are many machines now actually, but this is the most well studies. It has different types of machines, portable like and others, and it has the ability to detect fat as well as stiffness and the CAP score you're all familiar with. And I'm gonna talk about them because they're going to be included in scores in subsequent slides. So the CAP detect fat versus the stiffness is a reflection of fibrosis, and it gives you these 2 readings. And keep an eye on these 2 readings because we're going to use them in subsequent scores to tell us more things. So this is actually there are 2 really good papers about transient elastography cutoffs. Is the Eros paper or Sadiga's paper from the NASH CRN. And I believe this is the Eros paper in gastro, which is very good, especially it did the biopsy and the FibroScan within 2 weeks of each other. And those are cutoff values that many of us used to 74 as a start. Some people are used to 248 based on all data. I'll leave it up to you, but those are some of the papers. I think there's more consistency in the stiffness than the CAP. We all use the 8 as the cutoff for significant fibrosis, which is kind of F2 and higher. We use the 10 for F3 and we use 14 for cirrhosis. And I'll show you what the ASLB showed in a second. The ELF test has been also recommended by many societies guidance. And it's actually approved in the US for prognostic values, but values more than 9.8 predicted progression to cirrhosis, 11.3 and higher predicted progression to decompensation, but this is kind of like the values you want to look at. It's less than 7.7, the patients is in the safe zone. Now, what do we do in hepatology? There are many hepatologists here, so it's not like a FIB-4 and transient elastography story. We're trying to avoid biopsy. I don't stop when I have a patient with FIB-4 2.67. I go beyond that. So when they come to us, we start doing things like PDFF, MRE, CT1, Some people don't have it, but there are other things like you can do that you can pin it down. So it's also like we did this CPU paper for American Gastroenterology Association on lean NAFLD, and we started shifting toward the liver clinic and showing you what we do. And I'm going to start introducing scores like MAST and NAFLD and FAST score in a second. So this is the most recent ASD guidance by Dr. Ronella and colleagues. Many of them are here. It starts with the FIB4, then transient elastography. It gives you the same other values, but welcome to Windows. But also it goes beyond that, and it gives you other things that you can focus on. So I want to talk about this FAST, MAST, and NAFIB scores in a second. And what are the benefits of the MAST and NAFIB score, which I'm going to go to in a second. So actually, let me go back. I promise, I just looked at them and everything looked fine on window. But what I want to point out, here that they do a really good job in terms of differentiating who has significant fibrosis and where to stop at cirrhosis. And they do the cutoff here that I will refer you to the tables here. What is really important in this field that you know about the sequential testing. So someone walks in my office with a FIB4 of 2.67. I do other tests, and those are some of them. So MR elastography has been around for some time. It's very accurate, maybe the most accurate non-invasive test in detecting fibrosis. The benefit of that, you can couple it with MRI PDFF, and it can tell you in the same reading how much fat and how much stiffness the patient has. And this is beyond what we traditionally did looking at fibrosis and stiffness. We started looking for NASH and NF2 and higher. And the test that came in the guidelines, like the first one is the FAST score. And it was just like a mathematical model or multivariate that they came up with the CAP, stiffness, as well as the AST to look for NASH and F2. And you actually go and can apply it on an app and tell you if your patient has a NASH and F2 and higher. And it has two cutoff value, 0.35 for sensitivity of 90%, 0.67 of specificity of 9%. So you kind of can narrow it down there. The MAST score, we published it in JHEP, also was mentioned in the recent guidance. And the concept was simple. If the CAP by the FibroScan can tell you about the fat, the stiffness tell you about the fibrosis, and you add AST to that, gives you good value for NASH and F2 and higher. MRI is better in general, PDFF and MRE. So let's come up with another score let's see if it's more accurate. And we did actually another multivariate analysis, and AST came out, ALT came out as well, but they overlap. So we chose the MAST score, and it did better than the FAST score in looking at NASH and F2 and higher. MRIs are not available everywhere. This score actually, there's a formula online that you can get it. A paper from Rohit's group looked at the NAFIB score, which is dichotomous. Two values, FIB4 more than 1.6 and MRE more than 3.3, and it tells you who has NASH and F2 and higher. And I will show you like what we went beyond these values to keep an eye on the prize, which is outcomes. The CT1 has been also mentioned by SLD guidance. It's multiparametric MRI. And this is a pooled analysis published by Naima and Stephen, looking at a value of the CT1, which was 875 and higher correlates with NASH and F2 and higher. So another tool to be used, it's mentioned in the guidance that we need more data on it, but it's available in many places. The movements, Agile 3 and Agile 4. So I told you about FibroScan value of 8, FibroScan value of 10 and 14. Now the Agile 3 and Agile 4 are formulas that came to increase your confidence that your patient has F3 and higher, and Agile 4 for cirrhotics. And we started now using them for screening in clinical trials. Moving to response to therapy. So I think the best paper came from obeticholic acid data. Mauro is the first author on this, and what they showed here is change in ALT, AST, FIB4, transient elastography, maybe a bit ELF, correlated with changes in histology. I think what was probably missing in this paper is combining multiple biomarkers and see if a model of multiple of them will give you a better area under the curve for predicting response to therapy. And they mentioned that eloquently in the paper. So too many, especially like if I go to general GI, I was like, what are you talking about? NASH, NAFib, how are you doing? And all these tests is like, what do I do, man? Just like narrow it down for me and let me know what should I do. So here, if you want to put it together, so type 2 diabetes or 2 metabolic risk factors, do FIB4. Then you have the option to do transient elastography or ELF. Values more than 8 or ELF more than 7.7. This is when you refer to hepatologist. And in the hepatology ward, it gets way more interesting that we want to try to find those that they need therapies, and we look for the NASH NF2 and higher and use scores like FAST, MAFib, MAST, and CT1. And over time, let's say now GLP-1 is indicated for therapies to treat obesity, but also it helps NASH. But you can actually monitor your patient based on those. ALT changes, stiffness changes, changing fast. Actually, there's an abstract show that correlates with histology. And then in 6 to 12 months, you can repeat and see where your NIT is at, and then you either have response, you continue treatment, or you have no response, you can roll them into eventually another medications in the future. Finishing up with the outcomes, and this is, as I said, it's key for the field, because in order for me to convince the regulator that I need to remove the biopsy and have NIT, I need to show them these data. And I don't need to tell you like about what's the complications, ascites, hepatic encephalopathy, and variceal bleeding are the clinical outcome. I think the patient is in the middle, is Naeem laying down and trying to wake up first. So data showed, like Dr. Sanyal showed, this is data from Gilead showing you that we needed this kind of information. Fibrosis improvement and histology lead to improvement in outcome. We kind of knew that from hepatitis B and C data, but this is one of the first paper came from Gilead data showing histologic improvement of fibrosis leads to improvement in outcome. This is a paper also from Gilead data from thousands of patients published by Zubair showing you that baseline NIT such as ELF 11.3, NAFLD fibrosis score 0.67, and FIB4 3.25 and higher, and VCTE of 14 has high hazard ratio of predicting what we call it NALU, or clinical liver outcomes. This is a data that the ELF was approved on, 9.3 or 9.7 predict progression to cirrhosis, and 11.3 predict progression to outcomes, and the FDA gave them approval based on such data. This is a data from Jerome Boisier showing you that VCTE stiffness increase. The more stiffness, the more likely you're going to have clinical liver events, which make a lot of sense. And this kind of data that you need for the field to show that we can use them actually. The NASH CRM just presented data on that recently, and we wait for that publication. CT1 also has correlation with outcome. This is data on the left from our group showing you that MR stiffness of 6.5 correlate with decompensation and increase in stiffness. Each increase in 1 kPa gives you odds ratio of 3.8. Data from our with longitudinal assessment and much larger population showing you also increased stiffness, increase the hazard ratio of NALU. And then Rohit, Alina, and I, we pulled data together and we showed that increased stiffness lead on MR elastography lead to clinical outcome. And in this paper that the MAFib score also correlated with outcomes. So these scores are correlating with outcomes. And I finish with this slide, which is the last paper we published recently on the MAS score, showing you see statistics prediction of clinical outcomes of 0.92. So now you have the FibroScan, the FAST, MAST, and MAFib actually reflects what happens in the patient. And it's rationale for us to go to the regulator and say, hey, we really need you to try to replace that. Sorry, I'm a little bit over time, but this is my conclusion. There are multiple strategies that can be placed to identify at-risk NASH, which is the targeted risk population. In my mind, this is how I look at it. There's first generation of test, which is FIB4, even transient elastography, but we improved it by having scores like FAST score, MAST, and MAFib, and now Agile 3 and Agile 4. So you really can do these tricks in your clinic and know where your patient at. Well, and I think where we're lacking data is longitudinal assessment, and I think with resmetirom and obeticholic acid, we will know that, and always keep an eye on the outcomes, because that's what's going to shift the needle. And with the consortium that they talked about, I think we will be able to do that eventually. Thank you again, and glad to be here.
Thank you, Mazen. That was an excellent overview of all the NITs we have in the field. Our next speaker is also a dear friend, Dr. Alina Allen. She's Associate Professor of Medicine at the Mayo Clinic. Alina has published extensively in our field in AI, MR elastography, clinical care pathway. She's one of the most thoughtful physician scientists we have in NASH. So, Alina.
Thank you, Naeem, for the kind introduction. Let's see, how do I advance? Mazen, how did you advance? Is it through the top?
You push the green.
Okay, all right. So thank you so much for the invitation. Thank you for the introduction. Mazen, thanks for the wonderful review of the NITs. We know that EASL AGA guidelines have been in practice for a year or two. AASLD recently published. We'll take it a step further here to see how can we implement this in care pathways in clinical practice. And I will focus specifically on the linkage from PCP to GI and hepatology. The overview of my talk is here. First, we'll talk about what are NAFLD care pathways, what are their goals. Then we'll review challenges in real-world applications and end with ideas on design of multidisciplinary care pathways of the future. So the goals of NAFLD care pathways, I want to discuss these in the context of the multiple steps that need to be taken in the continuum of care of a patient with NAFLD, starting with identification of these risk factors at the level of primary care, following with the actual diagnosis of NAFLD, then risk stratification using the algorithms you heard in the previous talk with the goal of prevention of cirrhosis or identification of cirrhosis and prevention of complication. In parallel, though, an additional and very important goal is prevention of cardiovascular disease by optimal management of the comorbidities that can increase that risk. So NAFLD care pathways are the framework that support decision-making from risk stratification to treatment and care. They aim to identify patients at risk for NAFLD and fibrosis, minimize unnecessary specialty referrals to reduce healthcare cost and resource utilization, link patients with the services they need, and guide clinical decisions about the care they require. Note that primary care providers, PCPs for short for the remainder of the talk, have a central role in this framework, from screening to referral to specialty care, promoting weight loss, lifestyle changes, optimizing control of metabolic syndrome, cardiovascular risk assessment, etc. So collaboration between primary and secondary care is critical. So we need to develop effective systems that enable the partnership between these disciplines. You've seen this slide on Dr. Jeff Lazarus's talk, but fundamental to implementing a good model of care is clear articulation of the steps that are part of this. So the what steps and action need to be included in these models of care. Where are these services provided? Who specifically provides what? And how do patients navigate through the healthcare system? I won't summarize the care pathways. I did summarize the literature for you in 4 bullet points. There are about a dozen of these. The main conclusion is that most of them focus on the risk stratification using NITs with the 2 or 3 step approach discussed by Dr. Nureddin previously. The majority of the studies come, unfortunately, from UK. There's a large gap of these models in the rest of the world, including the United States. Only a few have assessed and shown evidence of effectiveness and impact on long-term outcomes. And in those which assess effectiveness, there's room for improvement in linkage between these specialties. And I will take one of these examples, one of the first papers, very nice papers published in JHEP in 2019 in UK, which used a 2-layer NIT pathway with the simple goal of identifying who needs to be referred to hepatology for advanced fibrosis, who can be managed in primary care. And what this the study undertook was an intervention arm by working closely with a group of primary care physicians who were educated on the protocol, discussed what this entails. This is what you see on the left side. And the model was compared to the standard of care of that local institution. What is showed that is a multidisciplinary model of care did decrease the unnecessary referrals, increased the advanced fibrosis percentage and that of cirrhosis. So it works, But I want to also point out to the fact that despite those PCPs being part of a known intervention randomized trial, 50% of them who identified patients at high risk did not refer them to specialty care. So even within an intervention trial, there are gaps. So how do these work then in real world? Let's review some of these challenges because there are several. Mainly because there's a centralized approach that relies on PCP. There are several time constraints. There is lack of uniform guidance and care pathways tailored to local resources. There's suboptimal knowledge and training, some of which you heard from Dr. Corey's initial talk. And there are unavailable structured disease management program. And I think it's important to stop and really think about these challenges because we cannot be forward thinking to implementation of effective systems if we don't understand what doesn't work first. So let's review the evidence. I'll review a few surveys that show what the gaps are. This is one of them led by Quentin Anstey, which shows that real-world management of NASH differs from clinical practice guideline recommendations across regions. They showed a lot of data here. I want to point out two things. One was that there was significant specialist variation in the use of FibroScan for initial diagnosis. And also only 68% of patients received non-invasive tests at diagnosis of fatty liver, and only 70% received lifestyle advice. A large recent survey led by Dr. Yunosi from the Global NASH Council, so here at home, on a large number of physicians, over 2,200, including PCPs, endocrinologists, GI, and hepatologists from 40 countries, assessed simply the knowledge about NAFLD around epidemiology, diagnostics, and treatment. And what this showed is suboptimal knowledge about NAFLD among physicians. And I'm pointing the primary care and others on the last column, but it was evident among endocrinologists and even gastroenterologists. And if you look at the second line, even identification of cardiovascular disease as the most common cause of death in NAFLD was recognized in 40% of PCPs and only 52% of endocrinologists. Big gap. Where did they learn about NAFLD? It looks like if we follow the purple bars that reflect the PCPs, they learn from guidelines and they learn from the internet. And what other barriers do they find in NAFLD management in primary care and endocrinology? The biggest one was failure of patients to adhere to lifestyle modifications, followed by lack of availability of effective drugs. So that leads to a lack of confidence in them being able to manage it, and hopefully with the approval of some medications, this will change. There were others such as time constraints and costs. Another survey looked at variation in the evaluation and management of patients with NAFLD across PCPs and medical specialties. This is a US-based survey, again, among the four areas of medicine. This showed very striking underuse of elastography or referral in primary care. This was a case-based survey, which specifically here asked, what are the next steps in a patient with high-risk NASH and diabetes with indeterminate FIB4? And you can see that only 10% of primary care physicians use elastography for further staging, and only 20% referred. Most of them relied on ultrasound and what appears to be aminotransferases. Huge gap, does not match what the guidelines would recommend. The other important piece is that multidisciplinary care is not the norm. In the question, would you involve any other disciplines in the initial management of a patient diagnosed with NASH? Very few would refer to endocrinology, obesity specialists, and so on. Even for dietitian, less than 60% of PCPs would use that. An important point also is that guideline use is suboptimal among PCP and endocrinology. With a specific question, which guideline do you use to manage, not to learn, but to manage management decisions for patients with suspected or diagnosed NASH? Very few used ASLD, ACG, or AGA guidelines. There were some reliance on institutional or own practice, payers, coverage, and guidelines, and 30% used none. So a large opportunity for us to educate and make sure that they are familiar with them. This is a last survey that I want to show because this is the flip side of the coin. This is a survey among mainly GI and hepatologists, and really asked what are the patterns of practice? What do they see when patients are referred to them? This is again a multi-regional study. And this shows that non-invasive tests are underutilized before referral to GI. What you see on the y-axis is the percentage of GI and hepatologists who said that less than 5% of their patients had an NIT before they got to hepatology. You can see that 50% of them said, if we go to the right, only 3% had a majority of patients with NIT before they got to them. More importantly, more than 50% of the referrals to GI did not have a NAFLD diagnosis by PCP upon referral. Most common referral indications were abnormal liver enzymes, high ferritin, fatty liver on imaging. Again, highlighting huge gaps. How do we manage comorbidities in GI and hepatology? We screen suboptimally. Not all patients are screened for diabetes, hypertension, dyslipidemia. Very few, about 30%, screen for sleep apnea. So even for us in our field, there's a huge opportunity to improve multidisciplinary care. So I'll end with some ideas on how can we design these pathways of the future. Can we learn from these? And what we learned from this review of the very current literature is that guidelines are the essential groundwork for the change, but are not sufficient by themselves. Because clinician behavior is generally difficult to change, we need an intervention with multiple synergistic components to influence clinician patterns. And we need multifaceted strategies which are likely to be more effective than single component strategies. So problems, we reviewed them, but they're nothing but a wake-up call for creativity. So how can we be more creative? What can we do to make this better in the real world? So I propose a system that we can all think, and I think this is a really nice community that we can think and take this further to facilitate implementation of the guidelines and then further multidisciplinary models of care in practice. And I propose that first, the coordinating team of actual boots on the ground who need to put these into the local practices are a hepatologist, a primary care physician champion, and I think an implementation specialist, because we need someone with expertise on how to implement evidence-based medicine in healthcare systems, looking through this through a triple lens, if we will, because if us as hepatologists will say, here's the guidelines, this is what you need to do, I think large gaps will remain. Second, I think an initial assessment of local practices patterns and the local barriers need to be pursued before we develop local multidisciplinary care pathway that address these barriers. And some examples that should be considered are use of NIT algorithms based on local context and availability. FibroScans may not be available to every PCP. MREs are not available everywhere, maybe ELF is not. Other considerations would be automation of pathways. Okay, is there a way to calculate FIB4 or a model and refer to elastography or hepatology in an automated way so we don't rely that every single step has to be done by PCP. We need to decentralize their role, not to remove them from the context, but to help them and empower them. Fourth, I think more coordinated care between clinicians should be done, making use of the local EHR by exchanging notes, automatic referral templates, anything that we can think that would work locally, or co-localization of disciplines, creating care bundles in diabetics and NIT pathways. More work needs to be done there. Next, educating clinicians more about guideline recommendations using online materials, local lectures, conference calls. We made them available, but as we saw in those previous surveys, they're not really used. Less than 40% of them look at them. And very important also, providing educational materials for patients, how to follow the lifestyle changes, medications to enhance adherence. And lastly, these quality metrics need to be reviewed in real time and adjusted to the pathway as needed as we move forward. Does this work in other disciplines? This is hot off the press, a JAMA paper from this year showing that coordinated care interventions, similar to what I just showed, can improve prescribing patterns. This is a intervention trial in diabetics with atherosclerotic risk factors with the goal of preventing cardiovascular disease. And simply what they wanted to see is if we split an intervention group of clinicians versus usual care and teach them how to implement these evidence-based medicines that these people need to be on 3 drugs, statins, ACE or ARBs, and SGLT2 or GLP-1 to prevent cardiovascular disease, can we improve the prescribing patterns? And as you can see with those circles on the yellow, it did work. 4 times higher odds to provide these 3 prescriptions in this intervention pattern. And more importantly, which is something we need to show in the liver disease field as well, do these interventions actually improve outcomes? In this study, they did. Intervention arm had lower outcomes, very hard outcomes, death, hospitalization, and urgent revascularization. So they need to be done right in order for them to impact practice and also patient outcomes. In summary, a few NAFLD care pathways have been implemented. There are several challenges that remain to be addressed, such as the barriers in primary care, including the lack of confidence and ability to manage NAFLD and patients' adherence, time constraints. Guidelines, elastography, and linkage to GIH care are underutilized. Multidisciplinary care is currently not the norm. So we need to think and implement multifaceted strategies for effective implementation of these NAFLD care pathways. And as we had this major effort of unified guidelines and multiple societies as really the ground for this, we need to move forward and use this momentum to create these pathways to implementation so that eventually we improve outcomes. And with this, I thank you and looking forward to the discussion.
Thank you, Elena. That was excellent. I would like to invite Dr. Lauren Castell and Dr. Orhat Limba to join us on a panel discussion. And we'll take questions for the next 20 minutes or so from the audience. I have a question, Dr. Allen. If you can comment on the use of digital platforms and maybe digital therapeutics as a way to scale these interventions that you discussed. And then a question for you, Dr. Mead. You mentioned all the NITs. I see a common scenario in my clinic when we do the FibroScan and the ELF, and they show us different things. And then what do you do? Do you biopsy these patients or do MRE? And if the MRE shows one thing, then do you believe it, face value, or what percentage of patients we're going to end up doing biopsy? So Dr. Allen first.
Thank you. Important question. I think the field needs to move into that direction. The data is very early. As you know, we are working on the decentralization component of PCPs, and I think there's a very great opportunity to include the EHR system, which we all really don't like, to work for us by using AI methods to identify these patients and somehow alert primary care physician, endocrinologist that the patient is at high risk. And I think this is where the area should move as we incorporate NITs and guidelines, and we have really stepwise pathways as to what needs to be done next. We can do this automated. Digital health interventions are the other piece that also needs more work. There's very early data. I'm not sure how ready we are for that, but I think it will be very important, specifically because these patients will need longitudinal care, hand holding, which sometimes we cannot provide on face-to-face interventions. Can we use these apps to continue their motivation and adherence to the guidelines?
Repeat your question is like when you get multiple NITs with multiple results, what do you do in your clinic? I mean, liver biopsy is still on the table. If you're in doubt at the end of the day, biopsy the patient, especially if you have advanced versus cirrhosis. So you can use it. I'll tell you what I do in my clinic. Especially I moved from places. The first thing in my mind, and I think there are few people on this table like they are MRE friendly. So the first step is to set the MRE well, if you can, in your institution, and know that your results are read very well. So in what I do in my practice, if I see discordance between, let's say, transient elastography and ELF, I go to the MRE, and I rarely end up biopsying patients if I'm confident that my radiologists know the MRE well now and it's read well, and you always can correlate actually when you do clinical trials and do biopsies, and you can tell if your MRE is doing well or not. Also, I think it's important to have hierarchy
it is clear that MR elastography is more accurate than transient elastography and ELF and others. So you need to take it a stepwise fashion to get there. A lot of us actually just jump to the after FibroScan to PDFF and MRE and call it a day to confirm it. I mean, many of us had this transient elastography of 14 and the patient is not cirrhotic, especially when you biopsy them. A lot of times I do MRE and I stop there. It tells me the patient is around F2 and higher. So in summary, use the liver biopsy as the ultimate gold standard. I think you probably have less than 10% if patients need a liver biopsy at the end, if you do it well. Know your tools very well and go for okay accurate to the most accurate, because the most accurate is more expensive.
So if I'm hearing you correctly, if you have two MRTs showing concordant results, let's say ELF FibroScan, we're done, we believe it. And then if we have discordant results, you go to MRE and you take that value. And then if you're still not sure, you do a biopsy. Dr. Linda, Dr. Castillo, what's your approach?
I also want to add to that, like if your transient elastography less than 6.5, I'm done. I don't need another test. So it depends what are you getting. It's like which, and I think most clinicians here know that when the transient elastography get to 14 and I have a BMI of 38, I'm questioning that big time. So
thank you, Naeem. Thanks, Mazen and Alina. I always go on the pretest probability because now the patient is already there with me. So if I'm convinced this patient has more advanced disease and any of the tests are not concordance with that opinion, I pursue. What I find is that I don't find concordance and I don't look for concordance on, say, ELF and FibroScan. They're more often discordant if you're looking at 9.8 and a 12. So that's a given. Or if you were looking at 10 kPa or higher, they're very discordant, especially in type 2 diabetics or 50 and older. So I think pretest probability is a key thing for me. Of course, we use a lot of MR elastography, and what we find, as Mazen pointed out, the hierarchy of things. If I'm getting a 5 kilopascal MR elastography, that is cirrhosis, except in the setting of people with other liver problems or NIH or something else going on. So I think sorting that out is really important, because when you get into that extreme discordance, it's really something else is going on with the patient, and they typically don't have fatty liver disease, is what I find.
If I may add, they're just tools. So the more tests you're using, the more discordance you're going to get. So to be very basic, I think in clinical practice, especially with an IT, the context of use is critical. And this is what Mazen has shown us. And I also agree with Rohit that the pretest probability is very important. If you're dealing with a 60-year-old diabetic obese patient, the pretest probability is very high. Then in practice, BMI also is critical. If you have a discordant result with VCTE with a patient of BMI above 40, I do not trust VCTE. And then I would use another test, MRE, but is not available or routine practice in our center, or go to the liver biopsy. So, I mean, it's on a case-by-case basis. I don't think you can recommend, but context of use is critical. And many people forget about that when you're reading the literature. Context of use is critical.
Dr. Charlton.
To thank the panelists and the organizers. It's been a tremendous morning. I wanted to just point out something which I think is something which is emerging as an issue for the field, and it's the outcome of use. So if we have, for example, these linear tests, these NITs, whether it's ELF or FIB4, but we're using them dichotomously, which has suited us fine up to this point because of clinical trial design, outcomes, et cetera. But going forward, if we do get a drug approved, they'll be used by payers as dichotomous, low risk, not low risk. And if you have, say, a 59-year-old versus a 60-year-old, FIB4, totally different meaning. ELF score is affected by gender, what you ate, BMI. So a FIB4 or say alpha, say 9.6 versus 10 might be different depending on, say, gender, BMI. So I think we need these linear variables to give us a percent likelihood of an outcome. For example, as MELD score does, as hemoglobin A1C does. So only people like Rohit and Mazen can really do that, generate a data set that will have an output which is linear as opposed to dichotomous?
So the question, just because the microphone wasn't working, is about the outcome of use, not just the context of use, and how we can utilize these NITs to provide kind of like a linear granularity of outcomes as opposed to just dichotomous endpoints.
I think this, oh, sorry. So this is a great point, Michael. Papers like Alina's paper and CGH showed like the likelihood with each one KPA you increase, how likely you're gonna get outcomes. We all three together and others worked on kind of high likelihood when you're gonna get outcomes, which is now MRE of 5 and higher. And there are trials now, like they put 6.5 of MRE as a point of decompensation. But I do agree with you that the continuous looking at this is the way to go. And it's the other way around too, right? When you have response to therapy, if you are moving from, I have a patient, he likes colors, and I tell him you're moving from the red to orange. And red is danger zone, orange is, this is always his analogy. And I think we're trying to do that with NITs now.
If I may add a further comment, I mean, this brings us back to the rule of 5 proposed by the Bavino criteria using liver stiffness. And this is exactly the point. I mean, it's linear and it's like a probability scale. The higher the liver stiffness, whatever the technique actually, we can discuss about the cutoff, the higher is the likelihood of developing clinical events. And this is where we're going. And I think we have to be relaxed with the cutoff. And it's true for cirrhosis, portal hypertension, compensated, decompensated. And it really makes sense. So I completely agree. But this is not true for P4, for instance.
Dr. Schanberg.
Thank you. Yes, I really enjoyed the discussion, and there's a lot of thoughts around, context of use, pretest probability. Congratulations. I'll extend that to Alina and ask her in the coordinated models of care, or the paper you showed. How could we not separate our referring physicians in primary care and high-risk diabetes cohorts, for example? Or what are your thoughts on how we can approach them differently? Should we start with diabetes patients or go to primary care directly? And then how do we get the message across that the same NIT might not be the answer for all of them?
I think NIT needs to stay. I think the question is, how can we start to make use of these models of care to really not miss patients? That's where we are. We're starting to do better than we were doing a few years ago. And I think starting with diabetics is the easiest, the lowest hanging fruit. So I think continuing a simple message that at least start with them should be the one to at least for now. But I think we need to do better to identify patients who may not have diabetes and other metabolic risk factors that can be at high risk for advanced fibrosis. I think it's a matter of narrative. How complex do we want to make it for them to actually implement it versus how can we simplify it to at least not miss the diabetics? I think the truth is somewhere in between. What I would say is start with a simple message, screen all diabetics, and then amplify that to a few more categories until everybody is familiar with the guidelines and do identify all the risk factors that are outlined in all the guidelines. It's my take.
Dr. Harrison.
Yeah, thanks. I think this is a rich discussion. I just want to add to it a little color from the payer perspective. So I had a really neat opportunity last week to go and meet with a group of payers that cover about 86% of the lives in this country through PBMs. And the one question that I thought was answered very clearly amongst the group was, when drugs are approved, will a liver biopsy be required? And the uniform answer was no. And I was very intrigued by the reply, and it was, we are going to fall back on the KOLs and their guidance recommendations on who to treat. And they're going to treat PA to label. That's a new phrase I had not heard before. So prior auth to label, whatever the FDA approves the label for that drug to be, that's what the pharmaceutical companies or the sponsors are going to pay for. So it's really incumbent upon really this group to define what meets the at-risk NASH definition. And to that point, what I'd say with FIB4, which wasn't ever designed for NASH, by the way, and is really designed for F3 and F4 patients from co-infection, Hep C and HIV. But we've kind of applied that into the NAFLD field and found it to be relatively effective as a screening tool. It's really a very blunt instrument. Okay, and as a result of that, what we're trying to get our primary care colleagues and even GI colleagues to do is to build muscle memory around testing for something, some simple test that they can use to target the low-hanging fruit. But really, it's this room that needs to drive better advancements in non-invasive diagnostic strategies using the prevalence of underlying disease to get at better tests for the frontline group of physicians that are seeing these patients, as we have the advent of therapy coming on board later this year.
So that's a very important point you bring up, Dr. House. And actually, I want to go back to the panel. So let's say the drugs are here and, we have a good way to risk stratify, identify at-risk NASH patients. How are we going to follow them in the clinic and decide, the treatment is working? Is it futile? When do we switch to another medicine? In my clinic, I notice a lot of variability with FibroScan. It is a little bit operator dependent sometimes, and experience is definitely very important. As you said, high BMI affects the results. ALT, there's, daily variability, right? It depends what time you measure your ALT can affect it a little bit. So everything we use has some issues, and you would hate to deny a patient the opportunity to stay on a medicine that's potentially working because you're not picking up that signal. So how would you guys do this?
I think the key question that Stephen mentioned and you're referring to, Naeem, is where would be the starting point? And the issue with starting point is the reason FIB4 is in vogue is because the outcome, as Michael mentioned, was advanced fibrosis. So how can we beat out patients who have stage 3 or stage 4 disease or maybe stage 2+? And so FIB4 is fine for that. One way to address the issue about losing patients who are candidates for treatment, if we go the FIB4 way, is potentially use a lower cut point. So we might consider moving once the therapy is approved instead of 1.3, maybe that's too high and we're going to miss a lot of people. We push it to maybe 1 or something based upon metabolic risk factors. And once you have 3 or 4 metabolic risk factors, the FIB4 doesn't matter. And then you may go on to actually testing with specific assessment, with elastography or ELF. So I think those are possibilities that we can move the needle, but it's not bad where we are currently with at least a framework of what a PCP can do. And to John's point, I think it's really important that when I talk to my primary care physician, I have complete clarity and I give them very easy instructions. And we build the clinical care pathways that are crystal clear. All the ambiguities should stay in our minds, but should not reflect in what we are doing at the population level in our health systems.
Can I add this is actually a very, very important point. And Stephen, I had the same conversation with payers before. I think we have responsibility here to make sure we don't shake their confidence with NITs. I personally would not use FIB4 to start treatment. I think FIB4 is a good first screening test. Then when you come to the hepatologist, I think you really have to be very sure who has NASH and F2 based on NITs. And I think the guidance started alluding to that. I think we're a good place at staging. Now, the response to therapy, I really invite everyone not to make it up how we're going to do it. Rather, I invite the people that they are submitting for approval, resmetirom obeticholic acid, to generate a lot of data to show us how their drug responds in correlation with NITs with good statistics, area under the curve, sensitivity, specificity, PPV, and NPV, and try to combine them to come with the best model to predict response based on histology as of now. I mean, we have data, Rohit showed data on ALT, there are other data on transient elastography, but with the 2 phase 3 drugs, you need to pin it down and have these thousands of patients and correlate the NITs with the response with the best accuracy, and then we take it to the payers. The last thing we want to do and say, use ALT or use transient elastography drop of 2 kPa, and then the data is not supporting that and it's all a mess in the clinic. I think the sub-analysis that comes after presenting the data that comes is very, very important.
Okay, I'll take one last question from Dr. Friedman and then we'll conclude the session.
Great, really thoughtful comments and presentations. The approval of drugs is going to be a game changer in terms of supercharging all these elements, NITs, everything else. But I wonder specifically for Alina, how should or would an approved drug change care models, jump-started? What should we do to prepare for that?
I'm actually very optimistic that it will improve it, because as you saw from that one slide, the biggest barrier for their confidence that they can manage NAFLD in primary care is that they don't really have treatment and patients don't lose weight. So I think having something in their armamentarium will be an impetus for them that, yes, I have a drug, I can treat it there, I will search for it. Therefore, I will search for it. So I think, again, we need to get back to that simplifying the message point that I had earlier. Because now we can say, we know who you should start screening. Now we can amplify that we have a drug for you that, by the way, treats not only diabetes, but fatty liver, for example, if that's the case, if like in Sema's case or any other that ideally have more than just liver-directed effects. So we can say, here's something you can use to treat all the problems that you're looking for. And I think that will actually resonate with them even more. So it's our job to make sure that message is received. And I think the guidances and guidelines put that point there as well. And I think we just need to, again, amplify this and use that momentum to take it to their ear.
Yeah, I think you'll also have obvious buy-in from the pharma sponsors who want to see the right patients get the drug for the right reasons. Yeah. And then, of course, payers who want to pay for drugs and patients who need it and where it will work.
Now you have the last word.
Now, if I may, Carolina, I think we have 4 guidelines in 2 years that are aligned for, so this is a very good sign. We have a drug coming, but we need to raise the awareness of our colleagues outside the field, PCP, diabetologists regarding NIT, because I can tell you I have a clinic in outpatient clinic in a diabetes clinic, they have no clue about NITs, and same for PCP. So this is our job, I think, to raise the awareness. We have the tools. We can discuss between experts about the efficacy. This is what we have been doing. But we have the tools. We don't have magic tools. They're already in place. FIP4 works. We need to raise the awareness of our colleagues for that, how to use them. And this is our job. And then I think the pharma also can help us to increase the awareness and educate our colleagues.
All right, so I'd like to thank the panelists and then hand it back to Dr. Zubair and also to take us through the last session of this morning. Thank you.
It was such a fantastic job here. This last session is between you and the lunch. So we're going to do this effectively. Jay is here. Thanks, Jay. And of course, we have Jeff and Scott. So we're gonna just address some of the issues and maybe have a little bit of conversation that we already had in the last session. There's been a lot of guidelines. The problem with the guidelines is that, yes, Johan, please come in. The problem with the guideline is that we go through all kinds of sort of assessment of evidence and put in these very nice sort of journals, but nobody implements that. Nobody actually uses guidelines. That is the problem that we have. Look at hepatitis C. There have been actually guidelines to screen hepatitis C for years. Actually, USPTF actually approved that guideline, and they're great drugs, very cost effective, and actually payers pay for it. You know how many people still have hepatitis C in the United States? Quite a few millions. And it's because the guidelines are not going to change behavior. What's going to change behavior of physicians, especially, and there are studies there where you have repetition of certain sort of requirements. And Jay, this is to you. Should we make sort of FIP4 testing as a part of quality metrics for primary care?
It's on my list. So, if I were king for a day, it needs to be a HEDIS measure. It needs to be something that we get accounted for or responsible for. And absolutely, I think you need to make it easier. We need a NAFLD panel, which is a single click on a lab test, like we just created for renal panel.
Yes, any other comment? Yeah.
I'll add on. I think that's a very important comment because we got to detach it from the physician or the nurse specialist ordering the test. It has to be there. It's part of the checkup. You go urine, blood pressure, additional tests, FIB-4.
And the problem, of course, is that if you look at hemoglobin A1C, and I looked at actually a recent practice that had 6,000 patients, and 3,000 of those patients had hemoglobin A1C around 8. And these were in the care of actually endocrinologists and primary care physicians. Here is a test already approved, already actually easy to do. Everyone has it, but no one actually acts on it. So asking primary care to take on something else when they have uncontrolled diabetes patients, they have patients that they need to do GFRs. How do we actually get this in endocrinology practices, Scott, to make sure that they think of liver or doing a FIB-4 as the same as a GFR or an eye exam? And then, of course, Jeff, you can also comment. Scott, you first.
I think that things are slowly changing, and I think it's better now than it was. But the challenge is, I think, twofold. One is that endocrinology and primary care are overloaded, and so adding one more thing is it's just a lot. But on the other hand, to look at it from the perspective of these are patients with metabolic disease, and this is just one more aspect of the diseases that they're already treating. And a lot of times the treatments are the same. So the lifestyle modification, the medications a lot of times are the same as well. So it's really recognizing the liver as part of all this and doing the FIB-4 screening, and especially identifying the high-risk patients that need referrals to hepatology.
Jeff?
Yeah, I agree. I don't think we can ask them to do one more thing. We have to automate this. And there are pilots going on where when we have the sample, the laboratories running the tests and running a FIB-4, and depending on the cutoff, then informing the primary care physician to inform their patient. And I think about how, like you mentioned, HCV, with reflex testing, I mean, it was so obvious that the labs should carry out the next test if the antibodies were positive, and that's not even being carried out all around the world. So, automation seems to make sense. It seems to be cost effective, but there's still going to be a long way to get there.
Any other comments?
Yeah, I would just say another comment about guidelines. We just heard that there are 4 guidelines that all line up for NAFLD. Just multiply that by 100 in primary care. So there's no way that we're going to remember all the guidelines, especially if not all the guidelines agree. So again, automating things and having unification is a really necessary step to do population health.
Okay, you're on one.
Yes, Zubair, let me be provocative and also channel the panel. I think one of the problems we're facing is that a lot of colleagues will say fibrosis is not a disease. Why should I screen for this? Okay, we're talking about some scar in the liver. Okay, maybe not ideal, but we have a lot of things on our mind. So maybe we, as a field, have to also step up and say, we're working in HCC prevention. We're looking at cancer. And my suggestion or thinking is, why don't we go into some of the cancer screening programs and say, we're going to do a colonoscopy plus, and Steve Harrison's done a great study looking at the prevalence in that population. And just whenever somebody goes for colonoscopy, do a FIB-4, or like go to breast cancer screening practices and kind of hitch on the malignant aspect of that disease. Not everybody develops that, but I think, in the discussion, maybe that's a step that helps to build the importance there a little bit.
I think that's a really good point. In the ACE guidelines, we tried to avoid the word fibrosis and use cirrhosis as much as possible because of that exact reason that I think people pay more attention to that word.
Yeah, maybe one thing we can, and I heard this from Melina, I think that was a great sort of, at least she alluded to this fact that we may actually need to go to develop a team of implementation of guideline that could be a multi-society sort of approach, where you're not just putting a great paper together and publish it in 1 or 5 journals, but actually have ways to then implement that. And this is really, that has global implication, Jeff. How do you see this in terms of, from your perspective where you're sitting? Because it's going to be, this is a global disease, obviously. And how do we actually make this it's sort of applicable to different societies, different countries with different willingness to pay for coverage and different systems that you know, some with national healthcare systems, some with private in this country. How do we make this so that, you know, that it becomes like hemoglobin C that's done in India, the same as US?
Well, if it is going to be uniform, it has to be uniform at the highest standard. But what struck me, you know, working 15, 20 years ago in HIV was there was an International AIDS Society. So every country in some regions had their societies, and I'm not calling in any way for the abolition of current societies, and they do collaborate and often, but not always collaborate well. But we need to look at how the societies can, you know, if we have 4 guidelines that are uniform, I don't know, but could we just have 1 guideline? And then, you know, so we need to think, you know, we have these, you know, joint statements and sometimes joint guidelines issued by the societies, but how can we increase the collaboration more and yet still respect, you know, the differences, because the societies respond to their regional context. But even so, the regional contexts are huge, which is why we need the national societies. So when I was at WHO, we often made, you know, like a global strategy, or we had global guidelines, and then they kind of trickle down with a minimum of what the regions and the different countries had to do to be effective. So that's kind of the approach I would suggest.
Yeah, and I think that's probably one of the most important takeaways from today, that this is a global disease and we have to globalize all of our approaches. And this is also a call to the pharmaceutical sort of folks. You know, they have to start sharing some data. You know, I understand that they are all going for applications and they've invested millions and they need to recover that. But for things that they can actually share, like the placebo arm data on NITs, things that can help move this you know, field forward, I think it'll be incredibly important to do this. Jan, from your perspective, now we talked about care pathways and Alina talked about different pathways. Which one is going to be more effective? You know, we've learned a lot about virtual care, you know, during COVID. Should we do, you know, even in hepatitis C, we had ECHO model, at least in the United States, that we used. Should we move more towards sort of virtual care pathways that's easier probably at some level than actually in person under the same roof?
That's a good question. And I think the virtual aspects was also in the previous session discussed as lowering the barrier where we can invite patients and screen them at an automated level. I think at the interaction level and to reflect on the importance of the tests we're doing with a patient, it's still required we see them and actually, you know, educate them, because there's always been a lot of concern about abnormal lab tests, and that might not be as relevant for the concrete patient. So I don't think we can detach it from seeing the patients and just having them automated run FIB-4s, because it's going to also increase anxiety with the patients. A good way in between to channel and guide the referrals to patients that will need it is required, and we need to spend more time thinking about that.
Well, Jeff, you've written something about this, or at least you're writing something about some different care models. Go ahead.
Yeah, I mean, I would just add, I mean, I agree on the clinicians need to see the patients. The question is how do they see them? Is it going to be through a camera? Is it going to be jointly? You know, in HCV, we've been able to advance where hepatologists and infectious disease specialists can prescribe remotely. Now, the patients have to be seen somewhere. They need to get tested. So in some cases, for example, people who inject drugs will only go to an addiction center and everything will happen there. And I realize that, you know, 8 to 12 weeks later, the story is usually over because they're cured, and this is going to be a lifelong issue. So we're going to need more contact. But, you know, tomorrow we'll talk a little bit about the disparities and inequities. We need to remember that if we do go more virtual and more digital, we're in danger of creating the digital divide, where we start to leave people behind, that people have trouble accessing services. But the last point is it's interesting, you know, where it is difficult to see patients face to face, like in parts of sub-Saharan Africa and in rural areas, they've really leapfrogged and used that virtual technology. So, you know, I think there'll be a lot of different combinations. And I guess for most clinicians, you're going to have a very busy day, given the prevalence and the number, a very busy life, given the number of people who are undiagnosed. So it'll just be a question of how to see them and where and how best.
So I'm going to ask a question from Jay, Scott, and Jan from different hats. So we've talked about sort of at least these 3 components. You know, primary care sees all, most of the patients, really. We only see the tip of the iceberg. And then, of course, endocrinology is probably most of the serious patients. And hepatologists, we only see a little. Who should own this care pathway with the challenges we have in terms of manpower, the amount of work that we have on our shoulders? Who should own it? Should it be hepatology driven, or should it be primary care or endocrinology?
I think it got to be very tightly hepatology guided. The comment Steve Harrison made on the payer side, they want us to identify the NITs and guide them on what we want to see. So I think clearly it has to be given, but I don't think it's owned by hepatology then. It becomes more and more obvious that this is something that we got to approach across these three disciplines, and potentially loop in cardiologists and who else is there. And just to add a little bit, I think if we're able to set up some auxiliary medical support groups, nurse or specialized physician assistant guided pathways and help us in managing all these patients, that will be crucial from my perspective.
Fantastic. Jay?
Yeah, I agree. I think the science has to drive that. And so I think the guideline gets started that way. I think that, again, you have to have reach, and reach is the problem. And so that's where you have to kind of jump on other things. I'd love for this to be one of the columns in the ADA algorithm. That's a great way to get that out to a lot of people. Or talk to the patients, let the patients own it, and let them drive the conversation.
Scott?
I might give a little different perspective being one of the only endocrinologists here, but the way that I look at this, and I think a lot of endocrinologists do, is that this is an endocrine disease, that metabolic liver disease, you could call it, and that it's diabetes, metabolic disease. This is the primary thing, and then the fibrosis, cirrhosis, this is the complication of it. And so when we see our patients, we're going to refer to the hepatologist, to the nephrologist when they get diabetic kidney disease, to the cardiologist, but the primary factors is mostly endocrine and metabolic. So we don't have enough of us to be the ones to managing all this, but I think that endocrinology needs to be a big part of the leadership of NAFLD.
Absolutely. Jeff, you've been focusing on encouraging cross-specialty collaboration, because at the end of the day, this is what's going to have to happen, because this is not going to be a disease of hepatitis C or hepatitis B that's going to be hepatologists. So last comment from you, Jeff.
Well, you just said it yourself. Hepatitis C, which sat with hepatology, moved to infectious diseases, moved to addiction specialists, and in some countries like Australia is sitting with GPs in most cases. So we need to look at, what's the mix going to be? Endocrinology needs to step up and be much more active. Hepatologists are going to be overwhelmed with the cases they see. So we need to look, like we've been saying over and over, how do we get the primary care physicians involved? How do we automate? How do we bring in nurses and other allied healthcare professionals? So it's going to need to be this sort of whole of health systems or whole of healthcare personnel approach.
Yeah, absolutely. And I think that's in the context of, shortage of resources, including manpower. At least in this country, both for primary care as well as for subspecialty. So with that, I think we're going to just end the session. I just want to summarize to say that we had really a great session, started with Jeff and with the epidemiology and some of the aspects of some of the aspects that we talked about, and then went to treatment. And really, Shira has been a superb advocate for lifestyle modification, and of course learned about drugs, both what's available right now and in endocrinology practice, but also Steve Harrison's view of what's coming down the pike. The NIT session, especially not only the NITs, but also the care pathway that Nina really covered, was fantastic. And having all of your wisdom here, hopefully we'll come back next year with some additional sort of insights for you. So thanks for spending your morning with us, and please go to lunch. And if we do for those of you who want to come back, there's going to be meeting here. Thank you.